were very good. So the take-home message is foraminotomies are an excellent tool. It's very easy to replicate if you're doing microscope procedure. Always do a pedicle to pedicle. 7 mm is a critical angle from the dura. It's easy to replicate. I believe that there will be a resurgence in orthopedic surgeons and the neurosurgeons now going back to foraminotomies as compared to doing ACTFs. Thank you.
Okay, next speaker will be the doctor from Japan, Kazuhiko Uchida. Any questions for the previous speaker? Yes, please.
Okay, thank you for a nice presentation. If you are doing a foraminotomy, we have to preserve 50% facet joint, right? Yeah. How do you know you moved 50%, 30%, 60%? How do you? Siam. Yeah. Okay, thank you so much.
I am Kazuhiko Fujita. Thank you so much, Dr. Malcolm Pestonji, for the opportunity to present. I'm from Aichi Spine Hospital, Japan. I'll talk about MELIF. ELIF is extraforaminal lumbar interbody fusion. Benefits of ELIF are no canal invasion, less muscle damage, good for revision surgery. However, it did not become popular because it is open surgery. Its surgical field is deep and dark, and it is technically difficult. Surgeons always worry about exiting nerve root injury. So we developed MELIF. MELIF is microendoscopy MED assisted ELIF. This is MELIF. This is MED system. It is good for lumbar disc herniation and spinal canal stenosis. MELIF allows cage insertion under endoscopic view, so we can avoid exiting nerve root injury. We can obtain additional benefits by MED. That's great safety, small invasive, and we can make it by one-man surgery. To date, we have performed MED a total of 120 cases at our hospital. 50 cases, 41% was at L5S1. Results. After surgery, low back pain and leg pain was significantly improved. 92% of patients scored good or excellent. The bone union rate 1 year after surgery was 70%. It is certainly low, but many cases take 2 or 3 years to obtain interbody fusion. And in some cases, we can only achieve facet fusion without interbody fusion because total facet joints are intact and stabilized. First case, this is a 61-year-old female patient with L4-5 degenerative spondylolisthesis. This is grade 2. MRI shows L4-5 severe canal stenosis. Surgical procedure. First, First, 4 skin incisions were made 5 centimeter lateral side to the midline. Next, we inserted 4 PPS guide wires. MED was docked to the lateral aspect of the facet joint. Approaching the disc from posterolaterally, the disc space is cleaned and expanded, and cage essential and PPS construct. This is video. Now using a chisel to obtain the bone graft. So meticulous decompression is made by a high-speed drill. Now I can see existing nerve root. I'm checking the disc now. Now I'm getting into the disc. A regular ring curette is used. A cage filled with bone is being inserted. You can see the existing nerve root and the inserted cage. A year later, after surgery, spinal canal was completely decompressed without direct decompression. X-ray after surgery, good correction at L4-5. Bone fusion was confirmed between interbody and the facet joint 2 years after surgery. Second case, this is a 67 years old female patient. L5, S1 isthmic spondylolisthesis. ME leaf at L5, S1 is performed in the same way as other disc level. The foramen is decompressed. You can see the existing nerve root and disc herniation. The disc is removed. I'm getting into the disc. 6 millimeter expander is inserted. 9 millimeter expander is finally used. A ring curette is used to clean up the disc. This tube is used for bone grafting. A metal expandable cage is being inserted into the disc. X-ray and CT images after surgery show good correction. This is MRI. ME leaf is minimally invasive because spinal canal is not invaded. Approach-related complication is barely seen. Disadvantage of ME leaf is we can only place single bolt type cage, so correction might be a bit weak. Bone union is inferior to other methods. We inserted 2 cages in several cases to improve stability and bone union rate. We try to insert 2 cages so that they catch the limb on both sides as much as possible. Conclusion. ME leaf is safe and produce stable results by a minimally invasive surgery in our 120 cases. It can be used as an alternative to other invasive lumbar interbody fusion techniques. It can be applied for cases with L5-S1 disorders. Thank you for your attention.
Thank you very much. That was excellent. I I was just wondering, on your scan that you showed, there was beautiful remodeling, or the canal opened up beautifully after a year. Do you think that's because of the stability that you're creating, and that's why it's or decompressing indirectly, or because of the cage height?
Cage height is first case.
On one of your MRIs that you showed, pre-op there was stenosis of the canal, and then post-op there was, after a few months, it was open.
9 millimeter.
So do you
cage
think it's
height.
because of the cage that you're lifting, or because of the stability that you're providing that the canal decompresses?
Canal decompress.
Did you decompress the canal? No invasion to the canal, right? Yeah.
Yes.
Maybe it's it's called remodeling. Maybe, I think. Yeah. Maybe both. Yeah.
Any other questions? Okay, so our next speaker from Iraq, Dr. Sadun. We're very excited to share this journey. I think we've all been at that journey, and it's an exciting place to be at, to be a beginner, but then to progress on to being more advanced. So thanks for sharing your journey.
Thank you, sir. I am Dr. Nafar from Iraq. I am orthopedic spine surgeon. My talk about something wrong. Dr. Razwan, please come. Okay. Something wrong, Dr. Razwan. خليها كبيرة. خليها كبيرة. I talk about the right side pathology with the right-handed surgeon in the UBE. For the first instance, I regard this subject as a little bit difficult to me only when I am new in the field of the UBE. Later on, I realized that the right side pathology represents something for many surgeons in the UBE. So, why we are worried about the right side pathology? Is it because a left hand is less skillful? Is it for the design of the UBE that making the cranial board is a scopy board, or for both? Is there any solutions? Changing the architecture, making the cranial port instrumentation, and the caudal port is scopy port, or improving the skill of the left hand? Can we improve in the skill of the left hand with the practice? Is the practice improving the skill? Practice making perfect. What are the steps that regard as pitfall steps with the left hand? Is it the triangulation? Is it the RF? Is it the rest of the steps? I found that triangulation no much differ whether it done in the left hand, the instrument in the left hand, or at the right hand. Also, the second step is the RF probe. Also, to me, it is the same. There is no difference whether I use the RF at the left hand or at the right hand, because we want just to move the probe like that to clear the edge of the lamina. Is it the bearing of the edge of the lamina? Also, it is the same. We just need to move the bear in this or in these movements. No need for more skill. Now, piercing the flavum, yeah, it is the most difficult and the most fearing steps when you did it in the left side, in the left hand, because we fear about we might injure the dura. So the most step that need more skill is the penetration of the flavum, and then of the phlebotomy, of course. We afraid that or the drop in the cage is need more care about like other steps, because the clearing the way before the drop in the cage is the important and need more skill. Are all steps are skillful steps or less versus all, some of them, or versus all of them? Okay, let's go to the approach. Really, I didn't find any literature that summarized the approach of the right side pathology. I'm trying to summarize them as follows. We have two main positions for the patients when do right side pathology: prone or kneeling position, or lateral decubitus position. Let's go to first to the prone positions. At the prone positions, we have two situations: when the surgeon is standing at the right and when standing at the left. Standing at the right, we have three approaches. First approach, which is the classical one, is the right instrument, right scopy, mean cranial scope. Scope is cranially at the right hand, and the left is the instrumentation, which is the classical, which is the little bit the troublesome positions. Second is the reverse of the instrumentations. Can we do it? Why not? We make the scope at the left hand and the instrumentation at the right hand. That means the instrumentation will be cranially and the scopy port will be caudally. Another approach in such set, we can, if we find difficulty to initiate the surgery with the scopy caudally, we can start with the scope cranially until do clearing the edge of the lamina, clearing the way, and bearing with the left hand. And then if we find it is difficult to penetrate the flavum, we can change the positions of the scope. We make it caudally and bring the instrument at the right hand cranially. So this is the when the surgeon standing at the right side. Can surgeon standing at the left side and do right side surgery of the UBE? Yeah, he can. There are two situations or two approaches. First, the surgeon stand at the left side and do the surgery by making the scopy port cranially, which is the usual, and the instrumentation at the right hand, and go on in his surgery. This is the first. There is little bit difficulty in this approach. When you're trying to tackling the medial tissue medially, little bit could be difficult when we try to reach in the medial tissue. Second approach is the right side contralaterally from the left side. That means first I will do the surgery from the left. I will penetrate and do phlebotomy at the left, and then go contralaterally and diving deep to the base of the spinous process, and then reach the disc there, contralaterally. Really, this approach, it's mentioned from some guys. Really, it is difficult, need high skill, hand, and it could be not so indicated. It could be increase the risk of complications. We destroyed everything until reach the goal. I not recommend everyone to do this approach.
Last minute, sir.
But it mentioned. Another position of the patient I mentioned, prone position and lateral decubitus position. Lateral decubitus position, I think this approach, it is the most promising approach in the future for the UBE. Making the patient laterally, in lateral decubitus position, the left side at the bed, and the surgeon at the back of the patient, and can do the surgery, left cranial, left scopy, and right instrumentation, as the usual, as the basic of the UBE. It is most promising approach for the UBE. We can lessen the difficulty in obese patients. Also, it is so comfortable for the anesthetist, for the patient, and I think for the surgeon. Thank you.
Thank you, Dr. Nafa Sudun.
We're happy to close this section. The next session will be chaired by Dr. Song and Dr. Shamansuf and Dr. Pandey. Yeah. Yeah, the next presentation speaker will be Ong Junhua. Dr. Ong Junhua, please. Yeah.
Dr. Jung, please. Share the presentation. Dr. Kumar.
Oh, can I start? So can I start? Yeah.
Next talk is UV posterior cervical foraminotomy and discectomy. Dr. Jin-hwa from South Korea, please.
Okay, thank you very much. And no disclosure. So in this case, you know, L5S1, left side, forearm disc herniation. Do you recommend discectomy first, fusion first? Discectomy first, right? What about this case? C67, right side, foraminal disc herniation. Do you recommend discectomy first, ACDF or ADR first? Maybe most surgeons recommend, especially American doctors, like ADR first. Okay. Yeah. So you know the posterior cervical laminatomy foraminotomy is a great procedure, long time. What's wrong? Yeah, but after Claude Smith Robinson, anterior approach became standard to treat everything about the cervical disc herniation. So disadvantages and advantages. Let's look at the articles, 20 years clinical outcome. Reoperation rate was 41.7% of ACDF and 10% of cervical CDA. Okay. But according to this article, 37% recurrent disc herniation requiring reoperation only for posterior cervical foraminotomy. And ACDF, about 25.6% at 10 years. Okay? So why can we recommend the posterior cervical discectomy, foraminotomy? Because we did the posterior approach with open surgery. So we worry about tissue stripping and wound complication and postoperative pain and not clear surgical view, and possible postoperative instability. So not easy for posterior thecarstic manipulation. Just before we mentioned about between tubular retractor surgery and microsurgery, posterior microsurgery and endoscopic surgery, we compared, and the endoscopic surgery have a better result. Why? What's the reason? Why endoscopic surgery has a better result compared to mini open surgery and microsurgery and tubular surgery? Because I think just the surgical view. With endoscope, we can see the surgical anatomy clearly, so we can save the facet joint more safely. If you cannot see the anatomy clearly, especially in the already you have experience with when you're using a tubular retractor in the posterior approach, sometimes bleeding from the foramen and the epidural space, we cannot control the bleeding. We cannot see the anatomy clearly. So that's one of the reasons. So we can use MIS tubular and uniportal, and we can use biportal endoscopic spine surgery. So indication of posterior cervical biportal endoscopic surgery, decompression is cervical foraminal stenosis, soft lateral cervical herniated disc, and prior ACDF with residual foraminal stenosis, and prior ACDF with adjacent level disease, and prior ADR with foraminal symptoms. We can recommend. The contraindication is calcified central disc herniation, instability, and significant cervical kyphosis, advanced cervical myelopathy patient, and predominant axial neck pain patient, and central stenosis patient, and history of prior foraminotomy patient. The possible complications will be infection, hematoma, and dural injury, instability. So this is biportal endoscopic surgery. So let's look at the indications. So the first case is cervical disc hernia C67 right. C67 is very easy, but in this case, HCD C56 left and herniation C45, C67. We can see the multi-level disc herniations. So, but we know what is the one clear culprit, okay? So do you recommend the ACDF of ADR, 3-level surgery? This patient maybe complain neck pain and sometimes right hand, left shoulder, arm pain for a long time, but can manage that kind of pain. But few months or few weeks before, suddenly, left side, serious radicular pain and neck pain, cannot control with the conservative management, physiotherapy, injection therapy. So in that case, we can strongly recommend posterior cervical decompression with endoscopic surgery. So we analyzed cases. Wall setup is like this. For safety, I recommend the walking portal. This case is my first posterior cervical endoscopy case. I recommend for beginners, you have to do C67 first. 667 level is easy. Don't try C5, 6, C4, 5 for beginners. Don't try to do. Anatomy is different. So you can see surgical view is very clear. So we can use conventional Kelson lungers. This is C67 right side. Actually, I recommend C67 level. We don't need to remove lamina passage too much, especially cranial side. Always, usually 67 level, the disc will come out in the axillary level. You don't have to explore shoulder level. But C4, 5 level, you have to explore shoulder axillary level. So we can see the ruptured disc fragment. Always, there is some remnant disc there. So we can explore with the nerve hook, and we can manipulate the cervical nerve. Okay? So we have to examine, we have to explore around the nerve root carefully. Okay, next case, 67 left side. Very easy. Okay, I recommend to start caudal part first. Okay, so C5-6. So C5-6, sometimes it's very, very difficult. I don't recommend for beginners. We have to explore shoulder part, axial part, we have to explore. Sometimes it's not easy to manipulate the root. So if you manipulate the root excessively, we have to worry about C5 palsy or some kind of motor weakness, numbness, or like that. Always we have to worry about there is some small fragment there. So I recommend use a little big hook, nerve hook. You have to use you have to explore the ventral part of nerve. So posterior MRI, C67 left side, it's very easy. You can see clear view, okay. So I visited Uzbekistan, and already this patient had corpectomy, but symptom was not improved. So I did posterior decompression. But still a little improvement, but not a significant improvement happens. For posterior wound is not important thing, I told you. So in the article, there is no evidence for difference. I don't believe that. They didn't analyze open surgery, semitubular surgery, tubal surgery, endoscopic surgery. So why biportal endoscopic surgery? Because of good surgical view and can use a conventional surgical instrument. So obesity is epidemic. So now I ask again, in this patient, if you are your family member, do you recommend fusion surgery first and posterior discectomy first? Okay, I recommend start open surgery first and tubular surgery and endoscopic surgery. conclusion, we have to change gold standard of posterior cervical decompression surgery. Thank you very much for your attention.
Thank you for excellent presentation. Is there any question? Dr. Hom, I have one question. When removing the ligament flavum, and a small part of bone around the facet joint, there is abruptly a lot of bleeding. How do you control the bleeding?
So in cervical discectomy case, you have to remove the facet ligamentum flavum completely because if there is a recurrence, and bleeding control, so that's not a big problem. If you could meticulously control the bleeding, but bleeding control from the ligamentum flavum is not important thing. So sometimes bleeding from around the perineural tissue, and epidural bleeding is sometimes very troublesome. You have to be very careful. It's not easy. Sometimes we cannot control.
Okay, thank you. In my case, I just wait for 20 to 30 seconds and flush, insert the flusher, and just after 20 to second, we control the bleeding. At that time, we doing the surgery. Okay. Next speaker is Dr. Urma Ruspi, biportal endoscopic contralateral discectomy and foraminal decompression.
Good afternoon, ladies and gentlemen. Thank you for the opportunity to be here. My name is Omar. I'm from Jakarta, Indonesia. And I would like to share our experience in doing biportal endoscopic interlaminar contralateral discectomy and foraminal decompression. So I'll begin my presentation with this case. This is a 58 years old female patient with the complaints pain in buttock to the left lower leg, and the complaint is just in the left leg, and there's no pain in the right leg, and also there's no back pain. So from the MRI, we can see that there is a slightly slippage in the L4-5, and also in the right side foramen, it is quite pinched, but there is still a little bit space there. But in the left side, the foramen of the L4-5 is completely blocked. And also, if we see in the axial view, there's a severe canal stenosis. And also from the dynamic X-ray, the spondylolisthesis is quite stable. So in this day, we already discussed about the consideration to doing the compression or do fusion. And if we choose to do the compression, we have to choose whether which of the structures that we would like to decompress, which is in the central, paracentral, or the foraminal, or both. Or is it in a single approach or in a double approach? So in management of spine problems, I think the main consideration of us is the patient complaints. So based on the patient's symptoms, the MRI and the X-ray and the CT scan is used to confirm the diagnosis. And also we have to consider the potential future problem. So our procedure might be if we resect many bone, we can create instability. So we have to consider about it also. For the foraminal decompression, the classic technique is introduced by Wills, and this is an open surgery and also can be doing by the tubular approach. And biportal endoscopy is also available to do this procedure. It has better visualization, has wide range of endoscopic view, and doesn't restrict by a cannula. And also the foraminal decompression is also able to do with the biportal endoscopy, either to do with paraspinal approach or the para-UBE, or we can also do a contralateral approach. If we are doing a paraspinal approach, it might potentially violates the facet. But if we do contralateral approach, it might be possibly gives us more advantage. And this one is a paper from Dr. Jin Sung Kim, which describes about the arc of the instruments and the scope, which is very wide if we compare if we are doing from the ipsilateral. So in the first case, we are doing decompression, interlaminar, central, and contralateral decompression, and also the foraminal decompression to the contralateral. So we begin from the laminotomy, and this is when we are finding the IAP. Yeah? The IAP, we are doing a resection of the bone, and after that, we are removing the flavum. We are removing the flavum, goes to the lateral side, contralateral side, and now we are reaching the foraminal, and we resect a little bit about the tip of the SAP. And the final result is we can see here there is a traversing route of the upper side and goes to the outside the foraminal, become the exiting route. And also we can see the traversing route in the down level. And I also confirm about the position of our instruments. It has become in outside of the foramen. This is our second cases. This is female, 73 years old, with both leg pain, but the right side dominant, and there's no back pain. And in this MRI, we can see there's a disc herniation, which is blocked in the right side of the foramen and also in the paracentral of the disc. So we can see here we are doing goes to the contralateral. Now we are finding the contralateral disc and doing dissectomy of the contralateral. So in this case, we are able to do the dissectomy of the contralateral and make sure that the contralateral foramen is free. So that's the exiting route that we are make sure that it is free. And this is the last case. This is 37 years old female patient, both side leg pain. And this patient has 2 levels of disc herniation. In L3-4, it is located in the right side, and in L4-5, it's located in the left side. So we are doing from the right side approach, the ipsilateral, the L3-4, we are doing an ipsilateral, and the L4-5, we are doing a contralateral dissectomy. So we don't change the position to do dissectomy. Okay, and this is our serial cases. We have 18 cases so far, and all the pain has reduced in the leg pain. It is significantly reduced. There's no major complication. There is no cases of neuropraxia, but it's fully recovered. It might be because my tip of the Carrison might be a little bit hit about the root. And there's no pars fracture during the surgery. So the indication to doing a contralateral foraminal decompression and also the dissectomy we can do in patient with central or lateral recessive stenosis with foraminal stenosis, central or lateral recessive stenosis with contralateral paracentral or foraminal disc herniation, more proximal L2-3 or L3-4 paracentral foraminal stenosis or disc herniation or foraminal stenosis. So because if we are doing from the paraspinal approach, it will be causing a violation of the facet joint, especially in higher level. And also for the stable spondylolisthesis with foraminal stenosis. For the technical notes, at first we have to do the assessment very careful to make sure which is the compressive structure and also the specific compression location. And we have to perform adequate undercut resection if we are doing to do the contralateral foraminotomy from the right side. Might be we have to do more bone resection, and also we have to resect the superior tip of the SAP to open up the neurovra. And this is also a study which from the Dr. Hyun Sung Kim in 2017, 26 patients of the biportal contralateral foraminal, 62.3 patient has a good and excellent outcome. Another paper also from Dr. Jung Hoon Park. It's in 2020, 27 patients, 96.7 good to excellent outcome. And also in 2020 and 21, 48 patients. It's from Ji Yeon Kim, 96% has a good to excellent outcome. So as the conclusion, the biportal endoscopic surgery provides access to do foraminal decompression from intracanal as well as doing contralateral disectomy. And the outcomes of neural decompression was good. And also it has many advantages. First one is the less bony resection, especially for the facet violation, and able to decompression both central and foraminal stenosis in one single entry. Thank you for the attention. And this one is we have a meeting in next August in Yogyakarta. It is our annual meeting and combined with ISSAP, and we would like to invite all the attendants here. Thank you.
Nice presentation, Doctor. Is there any question?
Dr. Omar? Hi. You're a right-handed or left-handed?
I'm a right-handed.
Right-handed. Suppose the patient having a symptom more on the right side, do you prefer go from the left side?
If the problem is in the right side foramen, I'll do from the left side.
Well, generally right-handed people used to prefer for contralateral decompression do from the left side. So do you prefer from the right side or left side?
Actually, firstly, I have to consider which is the compressive side. So if there is a central and paracentral stenosis and also the foraminal, and I have to do central and paracentral decompression up to the foraminal, I'll do from the contralateral. Even if I am either to do it from the right side or from the left side, I think it's not really a problem. But if we are doing from the right side, we have to resect more bone, because if we want to reach the contralateral foramen and also try to palpate the upper pedicle, it's more difficult if we don't resect bone. But I think since the base of the spinosus has a quite large bone mass, I think it's no problem and doesn't cause any instability.
If you can use both hand on contralateral approach, it is easy to access contralateral side. Okay, thanks.
Meanwhile, Dr. Asrafi, please come on the stage.
Other question? Yeah.
Thank you.
It's excellent presentation. I just wondering that the contralateral approach is also good indication for the upper lumbar level, right? And I saw your case is mostly in L4-5 level. Don't you try to, or don't you use this contralateral approach for the upper level as a first choice for disc herniation?
Yes, I think if there is a disc herniation in like L2-3 or L3-4, the contralateral disectomy is preferable. But sometimes I also doing in my early cases, I do in the complaint side. So if the disc herniation in the right side, I'll do from the right side. And if it's in L2-3 or especially in L3-4, I often make facet become violates, and sometimes it's distract. But no there is no instability happen. So I think, but in case of the spondylolisthesis, if we violate the facet too much, I think it will be cause instability. So yes, I think I agree. In higher level, we can do contralateral disectomy, sir.
Okay. There is no question. Okay. Thank you. Next speaker is Dr. Asrafi.
Yes, actually, I also replaced Dr. Rizky because of the visa problem here. Okay.
And okay, okay.
It's here. Yeah, it's here.
Next speaker is Pravin Share. Yeah. Next talk, surgical.
Yes.
Dr. Valencia.
No, actually, Dr. Rizky now is his turn, but yeah. So yeah, I replace him. Okay, so actually this is the topic from Dr. Rizky Gatam, and I also work alongside with him, so I will replace his presentation. So it's about the biportal endoscopic approach for excision of the juxtafacet lumbar cyst. Sorry. Okay, so for the introduction. Doesn't work. Sorry, technical problem. No, not that one. Not that one. That's my first presentation. Okay, so this is about the biportal endoscopic approach for excision of the juxtafacet lumbar. So for the introduction, the juxtafacet lesion is a benign lesion that is grow at the level of the facet joint and within neighboring structure. And this is the example of the MRI of the juxtafacet. So we can see here the facet is compressing the nerve root and also the thecal sac. And the incidence is quite rare, and the pathophysiology until now is unclear. But it is suggested that it might be because of the increase of the load in the posterior vertebral elements, or it could be because of the weakening of the facet capsule or PLL, and might be also related by trauma or rheumatoid arthritis. For the patient symptoms, mostly is the radiculopathy, but sometimes it also happens a back pain in this patient. And the case is mostly comes in L4-5, and from the MRI appearance in the T2, we can see hyperintense in center with the hypointense in rim, but in T1 it's fully hypointense in the inner core. How about the management? The management actually there's no guideline, and mostly treated by the open surgery, but there are some problems that might be encountered. The first one is about the addition to the dura mater, and also if we try to excise the facet, it could be cause a dural tear, and also there's also a risk for instability after surgery, especially if we resect a facet too much. And also we already know that endoscopic surgery is one of the choice and give a better visualization, and also gives advantage of the less muscle trauma. This is how we can approach to excise the facet cyst. Actually, we can do either from the biportal or from the uniportal. And the approach we can do either from the transforaminal, interlaminar, ipsilateral, and also the contralateral. Each of them has their own advantage and disadvantage, and also we have to consider where is the facet cyst is located. This is a paper from Dr. Martin Kom and also Dr. Sebastian Rutten about the facet cyst. If we can see here, actually the facet is in the extravoraminal part, so they are doing from the transforaminal approach of the endoscopy. And also a paper from Dr. Jung Sung Kim also, and he proposed also the biportal endoscopy to excise the facet joint, the facet cyst. And here is our case. We have a facet cyst in level of the L4-5. In the axial view, we can see the facet cyst located in the left side, and also it's attached to the PLL. So here is the video after we are doing a laminotomy. Now we are approaching, we retract the nerve, and we can see we are trying to pull out the facet cyst. Yeah, we are using hooks. In this case, we are doing from the ipsilateral side, and finally we can completely remove the facet cyst. Yeah, that's the facet cyst. Okay, so this is the MRI post-op. We can completely excise the cyst. And this is the second case. The second case is also a facet cyst which is located in the left side, but it's located quite in the facet joint. And we are doing, in this case, we are doing from the contralateral side. Actually, if we are doing from the contralateral side, also we have another advantage. The main advantage that we can visualize clearly the attachment of the cyst to the dura. So if we are doing from the contralateral, it will be more difficult to see the border between the cyst and also the dura. So we do flavectomy here and find the cyst, and we have to be patient to separate between the facet cyst and the dura. So after we can identify and separate, we can cut the tail in the proximal and also the cranial side, and we can resect the cyst also in end block. Yes, that's the cyst. And this is our last case. Last case is this is also a facet cyst in the right side, and also located in the foramen. We are doing from the ipsilateral side. Here is our video. So we find the facet cyst, and if we are doing from the ipsilateral side, as I mentioned before, sometimes it is quite difficult to differentiate between the facet cyst, especially when it's quite attached to the nerve structure. That's the facet cyst. Okay, and we make sure that there's no compression. So far we have 10 patients of the facet cyst, and there's no residual symptoms after the surgery. One patient had recurrence of the facet cyst, and probably because we don't resect completely. And one patient had a dural tear during the surgery, but we can manage with dural patch application. For the conclusion, the facet cyst is not a common condition, and the neurologic symptoms almost always occur in patients with this condition. The approach of the facet cyst excision might better from the contralateral to evaluate this the cyst wall, and endoscopic surgery provide better visualization for the cyst wall. And option of open or endoscopic procedure is depending on the surgeon's preference. I think that's all. Thank you for the attention.
Thank you. Excellent presentation. Is there any question? Yes.
Any incidence of facial cyst developing maybe after 6 to 2 months after doing a UV decompression in a lumbar canal stenosis case? You said one recurrence, but that was your facial cyst. You did cystectomy.
It happens
again. It developed.
Yeah,
but here I had a case. I did a canal decompression, and after 2 months, patient had a severe radicular pain, and on MRI there was a cyst. So I am asking any experience with my colleagues of this sort.
So previously, there's no when you are decompress, there's no facet cyst, but after you decompress, the facet cyst is it's occurs, right? No, I think all of my cases we find the facet cyst since the first case.
Okay, thank you. Thank you, Prof.
See, I have only one comment to make. A post-operative facet cyst, if it is going to develop, it will develop in an open spine surgery. It is going to develop in Destando. It is going to develop in any surgery. If it's not going to develop, it's not going to. Moment you tear open the capsule, and you leave a small capsular opening, because that is sometimes not even seen by the human eye. You know, your instrument just poked the capsule. Now you have a small capsular rent. You have not even seen it. It can start bulging and forming a cyst over there.
Malcolm, in last my 18 years of experience, dry endoscopy, Destando or arthrospine, I never came across such developing. This is after fluid, that's why I was asking the house, any experience?
If you undercut the facet, there is very less chance that patient will develop a cyst. Because you have damaged that facet.
But here it was,
it will fuse. There, yes.
So anyway.
But he told that there is a canal stenosis and he did the decompression.
So, can I have my first?
Next speaker is Moinder. His talk is dual spine endoscope, principle and rationale.
Thank you, Chairman, sir. Good evening, ladies and gentlemen. So I will be sharing my experience on dual spine endoscopy. This is again a kind of innovation. This is a kind of a reinvention from Destando technique to beyond, how we can address more and more complex issues which we could not address with the Destando technique. So my disclosures. So what is innovation? Innovation to me appears, I can say that it is successfully implementing a new idea to improve patient outcomes by providing new and better treatment options. Now, dual spine endoscopic, why? The principles and rationales remain the same as of minimal invasive spine surgery or endoscopic spine surgery. That is, it should be minimal invasive, direct visualization, preservation of surrounding tissues. It should be a targeted, small surgical footprint and preservation of the motion and spinal stability. So we have existing interlaminar endoscopic systems in our armamentarium. Destando was the one gold standard, which I think 1993 Destando embarked on the journey of spine endoscopy. It relies on conventional dissection. Then we have other systems, arthrospine and EasyGo, which works on a muscle dilatation. Then the saline came in, and saline UV is a conventional, we all do know these techniques and conventionally the way we are doing these procedures. Then dual spine endoscopy, we have I in fact innovated this technique in 2019 when I visited Dr. Sohn after seeing the clarity and the advantages of the saline. It was working in my mind how I can incorporate these principles in Destando technique or a arthrospine tube, which is a kind of a miniature Destando technique. So other systems we have is PSLD. And to me, it appears youngsters are showing more and more interest in tubeless endoscopy, that is unilateral biportal endoscopy. This is what, when we conduct courses, more and more youngsters are coming to attend these courses. So applications, the system can be used in cervical, thoracic and lumbar discs and canal stenosis. I have used them in infection, debridement and biopsies, and they can be used in dual pathology also. And advantage of dry and dual endoscopy is where you are using a judicious fluid use, so no need of drain, no fluid-related complications, and even when you switch over to UV mode, you can go ahead with the fusion also, which was a limitation with the Destando technique or arthrospine. So this is just a reinvention of a Destando philosophy, you can say. Some of the issues which I was facing in Destando technique, I addressed those issues here, and you can see one of the issue was when you are addressing, there is a staining of the scope tip, and then with the fluid coming in, you can see the clarity is much better. So, and when the surgeon is wanting to go ahead with a fusion, then he has to switch over to a UV mode. And here is a tube or sounding technique, which again is innovation. A guy who wants to switch over from Destando or arthrospine to a UV technique. So to my younger colleagues, when they wish to embark on a spine endoscopy journey, they must understand the philosophy and principles of various techniques, interlaminar vis-a-vis transforaminal. Surgeon may have to familiarize themselves with all techniques and choose the philosophy and technique that they want to embrace. So it is a classic arthrospine due technique, is a classical posterior interlaminar approach. Anatomy and inside view is like Destendu technique. And it is again a mobile system. It has all the features of Destendu technique. It is a, you can say it is a miniature Destendu tube with a smaller diameters. And when the surgeon is switching over to saline mode, there is a tube. When he switches over to saline mode, it works like a principles of PSLD. And here you have all the advantages of a saline. I'll not go into the details. And here you can see the instruments, they go well beyond the tube when you are switching over to the saline mode. And clarity also becomes better. So very simple instrumentation. And 2019, when I visited Dr. Sohn, when I came back, I was finding there's no dead space there. Like in a knee arthroscopy, when we are doing, there is a space available there to the surgeon. Here, there is no dead space, and you are struggling within the, under the muscles. So I found there is a difficulty in triangulation. You are lost in the soft tissues. There is a red out phenomena. Excessive radiation is also an issue here because you are taking a lot of AP views, and soft tissue swelling does happen. And there is an excessive soft tissue RF ablation when surgeon is trying to create a space under the muscle. And here is a sounding technique which I found is very, very useful for early learning time. You can see here that with the Destendu tube or arthrospine tube, when you have done a decompression, you have exposed the disc, then this is a Visinger rod which we use in shoulder arthroscopy. You can see here how it is sounding. It hits the tube over the lamina, protecting the neural structures. And then this sheath, arthroscopic sheath or a single port sheath slides over the shoulder Visinger rod, and the surgeon slides the scope, and then he puts in the scope and the camera, and he starts working in a UV mode. Now the tube has been removed, and that port becomes a working port or a UV port like we do in UV technique. So simple instrumentation, nothing big, only few retractors they come in when you are planning a UV instrument technique. Indications, again in arthrospine due philosophy remains the same as open spine surgery. And initial steps, I will not go into the details. Patient is prone, but we do keep over the bolsters. We don't do a knee chest position because at times you have to take a AP view, then that becomes a problem. So bolsters, they help you in that. And here you can see there is a up migrated disc, and you can ably address it in a dry mode. And if you wish to, you can switch over to a saline mode also. Details of the technique I'll not go into. So it was such a huge fragment that it was not coming out even through the diameter of the mouth of the tube. So tube has to be withdrawn to retrieve this big fragment. And this is again a down migrated disc here, you can see here. So all types of disc herniations can be addressed by this technique. This is, we are working in a dry or a Destendu mode. And ball tip probe is a very good and a nice instrument. And this is how surgeon can retrieve the huge fragment under surface of the dura and then take it out. And this is again a redo disc procedure. So expose the bony landmarks, stay away from the scar. Then you switch over to saline mode and then can start to, you have a more closer view of the surgical area, and then you can see the fragment or retrieve it. So there is a fragment which then surgeon can remove it. So view becomes more enhanced and clear. So this is a lumbar decompression. So that is, I feel, inside view is better when you're switching over to a saline mode. Again, this is a two-level decompression through a single port. I mean, we have not used, this is a uniportal endoscopy, means we have not even used two port for this patient. And cervical discectomy, already my colleague has shared that video. So this is how you retrieve these fragments also. So most of the pathologies can be addressed by this dual technique, and surgeon is quite comfortable when working close to the dura when the saline mode is switched on. And you can retrieve the disc fragment like this. This is a cervical aminoforaminectomy. This is the disc fragment which is retrieved. And this is again a cervical canal decompression. So you can address all those pathologies with the saline and dry technique. Since we graduated in, we mastered dry techniques, then we graduated to saline. I feel it is surgeon's call. You can complete the procedure in dry mode also, saline mode also, as the surgeon is comfortable. So this is my journey in last about, say, since 2002, I am into a business of spine endoscopy. And I have extended my indications to various other procedures also. And I had my shares of complications, dural tears, discitis, nerve injury, recurrence, superficial wound inspections. And word about learning curve. I mean, spine endoscopy is not everyone's cup of tea. A guy who is not cut out for spine endoscopy, he should look for other alternative methods of dealing with the spine problems. And to summarize, rationale behind dual spine endoscopic spine technique is to provide patients with advantages of dry and saline endoscopy. Technique complements UV when planning endofusion. Innovative Dr. Kaushal's triangulation sounding technique helps minimize UV learning curve, radiation, and excess tissue RF ablation. Judicious fluid use minimizes fluid-related complications. So from Destendu to a dry mode, then saline mode, and then UV mode. I think this is what I can say. Destendu user, orthospine users can graduate to a UV mode whenever they feel the fusion is planned for a patient. And thank you very much. And I welcome you all to a 15th spine endoscopy update and 6 UV live and cadaver course 2024, which is going to be held in City Beautiful, Chandigarh, India. Thank you very much.
Thank you for a nice presentation.
In fact, this is the original article published in one of the Korean journals. It will be seen, I think, in the forthcoming issue.
Can you use this instrument with both the water and dry?
Beg your pardon, I couldn't get your question.
You can use this system. We both irrigations and the dry.
Yeah. It is a dual mode, yeah.
Yeah. Okay. Is there any question? Okay, thank you so much.
Thank you.
Next, the rest of the case will Dr. Soman Suru will have the rest of case.
Next presentation is Dr. Srinivas Rohita sir. This one, he's written.
I'll talk about 3D endoscope in the endoscopic spine surgery with distant use technique. This is what I have consistently doing it since 2002. I have focused on it and I did it persistently, and I tried that lets other know about the technique. This is the advice for the youngsters. Don't try multiple technique once, but try one technique 10,000 times to be a master. This is for the younger generation. This is by Bruce Lee. MISS is minimally invasive, but I try to explain to my patient that it is endoscopic spine surgery because we are maximally invasive at the site of the pathology. This is in short from 2002 to 2024. Lumbar cases, lumbar canal stenosis, percutaneous cervical endoscopic, anterior cervical, posterior cervical, intradural tumors and everything. Since 2017, I have started using 3D endoscope, but I first used 3D endoscope in 2015. This is by Baker in 1990. He first described the 3D technology for endoscope. It allows better recognition of the relationships of the anatomic structures and makes precise differentiation of tissue layers. Basically, endoscopic spine surgery is a concept. It refers to concept, not the size of the incision. This is what we started in 2002. Single chip, xenon light, did workshops. This is in single chip camera, xenon light. This is anterior cervical. And there was always skepticism that there is no depth appreciation and it's more stressful and risky. This is the anterior cervical, medial to the vertebral artery, disc preserve in surgery. And when we started using drill, there was always stress when we were near the vertebral artery or near the root in the contralateral lumbar region. So we thought of anything which is more safe, remove the bone, and it will not damage the neural structures or the vessels. And this was the development ultrasonic bone dissector, which was more safe in removing bone in near the narrow corridors or near the vertebral artery or subcarotid. This is the initial thing. Then came the HD camera in 2008. The anatomy was quite clear. We could have depth appreciation more precise, but still there was a skepticism that there is no depth appreciation because it's a 2D image. Here you can see we have removed the outer layer of the flavum, the inner layer is still attached to the bone. So there was still skepticism that there is no depth appreciation. So we thought of 3D techniques, conventional techniques. Initially I used Vision Sense, then Mashida, and since 2017 I'm using STORS. This is the first case which I did with the 3D endoscope in 2015, which was a Vision Sense. It is an intradural tumor at D12L1. This is the 2D image of 3D. We can use micro scissors also. This is the endoscopic bipolar with a curved tip. These are the cases of canal stenosis, intradural tumor. This was the Vision Sense 3D endoscope. With two lens size, So insect eye technology, multiple images are converted into two images. One is the clear image, one is the blurred image, and then you get the depth. This is the canal stenosis case, ipsilateral and contralateral root with the forearm anatomy. We are able to appreciate the depth. It's a endoscope which is 3D. At the same time, you can move around like a mobile microscope. Then I tried this the Mashida, which is 3D converted. It converts a 2D image into 3D. And then since October 2017, I have used STARS endoscope, very light, autoclavable. These are the images. We have two images, and when we convert, when we relay it into a 3D screen, we can get a depth. This is the 2D of that 3D. You can put the endoscope inside the disk space. So till now, with 3D, 919 cases, lumbar 829, anterior cervical 18, posterior cervical 16, interdial as well 20, thoracic 4. And I did recurrent disc 32. 11 of them are open, after open, recurrence after open, 21 after the post-endoscopic. I had 18 dural punctures in 817 cases. Simple muscle piece, as there was no need of suturing in 9 cases. Muscle, tissue dura patch or fibrillin glue in 9 cases. Canal stenosis with listhesis, I had 6 dural punctures or tears. Only discectomy 6 and discectomy with canal decompression 5 cases. And there is 1 leak in the recurrent endospine case. So it was successfully carried out without any extra time or fatigue. In canal stenosis also, even if the surgery lasts for 2 hours, there is no fatigue. Definitely best for canal stenosis where you need angulation and go to the opposite narrow canal. There are some pitfalls. In endoscope, with the 3D endoscope, there is a tubular vision. There is no panoramic vision. We cannot have a zoom effect because there are 2 lenses or 2 chips. Because there is no panoramic view, all the endoscopic field have same illumination. I have not thought of any UV because it's a very costly endoscope. It is just like a mobile microscope. 3D appreciation will definitely decrease the steep learning curve. 3D anatomy will help in explanation of the disease anatomy like compression of the nerve to the patient's relatives and even the patient himself. 3D appreciation is definitely helps in reducing the complication related to the depth appreciation. These are the disadvantages because with the Distando technique with 3D, it is the costliest endoscopic system. Endoscopic basic panoramic vision is not there, as there is no panoramic vision because there are 2 chips. This is how the Distando system works: outer tube, inner tube, instrument in the right hand, suction in the left hand. But we can have a telescoping effect in between the outer tube and working insert so that we can have a zoom effect. Pulling out of the working insert, we can create a working space for the instruments. And mobilization of the instrument in all directions without changing the focus and having the 3D endoscope, it will work as a mobile microscope. This is how the angulation remains constant. And that's how we can have a 3D endoscope with the Distando technique. We can have a zoom effect and the loss of panoramic vision we can compensate. This is how we can move in all directions. Because of 3D, I have aggressively starting using the retractor, aggressive use of drill and cutting drill. significantly less use of ultrasonic bone dissector because I was using ultrasonic bone dissector in all cases of lumbar canal stenosis. I have stopped using it. I only use the ultrasonic bone dissector in cervical cases. This is what we have our workshops in our place, dedicated workshop for 8 delegates only, full day cadaver, 9 to 5, and 2 days of cadaver, 1 day inside the OT with the 3D explanation of the 3D anatomy during the surgery. This is the 3D endoscopic cadaver training workshop. Thank you.
Thank you for excellent presentation. Do you wearing the 3D glasses?
Yes. The next generation will be you don't have to use the 3D glasses. The screen will have a stereoscopic vision. That will be the future.
When I experienced the 3D endoscope first, I felt a little dizziness. How about you?
I never felt that because I wanted to use that because I'm a neurosurgeon. There was always skepticism from the neurosurgeon that this is not microscope.
Okay.
So I wanted to use that. I'm using it.
Thank you.
I never had any fatigue or dizziness or headache, something like that.
Thank you. Is there any question? Okay. Next.
Next presentation is Dr. Paresh Day, application of the Destandu technique for challenging situations.
Hello friends, after the all advanced and modified Destandu system by Mohinder and Rohidas, this is a simple Destandu technique where I am using regularly. This is the few cases I am going to show you. So about the description, you know that it is already mobile operating tube, few instruments, very strong and stout. Once purchased, it will go on about 20 years. It is an interlaminar window approach, fresh fit technique. Both the hand of the surgeons are free, left hand for the suction tip and right hand for the operating instruments. No need to hold the telescope. And at the same time, few instruments only. Now come to a patient of 52 years, extruded and migrated, upper lumbar, that is L1, L2. And after that, it is extruded and migrated almost one level above, that is the D12L1 level. So this is the bit extra removal of the bone from the cranial lamina, the exciting nerve root and traversing nerve root in front of you, and we have removed in toto the disc, the single piece 6 centimeter long, after 4 hours of the surgery and after 15 days. This is pre-op and post-op. This is pre-op MRI and this is the post-op MRI. 42 years lady, complains of the severe pain and radicular pain for 20 days. Similar attack twice, about 2 years before and 9 years before. Now that is all conjunctival fails. This is extruded and migrated downward, that is L4, L5. And this is the L4, L5 left side. So we have given the mark, we have a special decollaging device, and we have removed a bit, maybe 2 to 3 millimeter of extra bone from the foramen and inferior lamina. So mobilize the nerve root up to the foramen. Then I have given a patty both cranial and caudally. Nerve root is even now free and just extruded and migrated downward disc. In toto we are removing. She was very happy in the next day morning. 52 years lady, hard disk, two level, 455S1. So my 11 number blade is not able to pierce. The disc force tried also fails. Then I use the Kerrison punch, as is a open surgery and open microtubular surgery, same technique. So you can use the same thing, same technique, same orientation as a destined is also the same thing. Another patient, 56 years male, complaints of the left radicular pain, severe pain, cauda equina syndrome for 3 months. He was almost bedridden. And this is a 4-5 level disc. But the complaint was in the right side. Sorry, complaint in the left side, and there is a hard disc in the right side. So I approached from the left side, and then we remove the disc. We dig over the top, we went to the opposite side, and decompressed the nerve root up to the foramen. Then we found out the hard disc of the opposite side, dissected a bit, and fibrosis, everything is dissected, and removed the disc, hard disc from the opposite side. The next day morning, 33 years male, the 9 months severe radicular pain, all conservative treatment fails. Similar attack 6 years and 2 years before, 3 level disc, 3, 4, 5, 5, 5 S1, 3, 4 is the left side, 4, 5 is the left side, and 5 S1 is the right side. So we approach from the 3, 4, 4, 5 from the left, and 5, 4 is the right side. Now these are my publications. Now come to the recurrent disc, 62 years lady, laminectomy and bilateral decompression, open surgery, 455 S1 done in 2012. 2014 there was a recurrence and excruciating pain. She has taken an epidural block that relieves for 3 months. Again there was severe pain. You can see in the left side AP view, there is a lamina, the laminectomy done. This is a laminectomy done, and then in 2016, she came to me with the right side, L4, L5, extruded a bit upward migrated disc, recurrent disc. Small video. So there was no lamina. So we hit the medial aspect of the facet, bit removal of the bone, and retract the fibrous tissue. In between the fibrous tissue, we got a space to go in. Then the nerve root along with the fibrous tissue post-medially, we have removed sacrificed a bit of the medial aspect of the facet. Next day, 50 male, disc herniation L4, L5 and extruded and migrated downward. This is a right side disc. This was the situation after the 6 to 7 months. You can say it is a neglected or maybe partially removed disc, some left out disc. So this was in July 2016. We did the contrast MRI. That is shows there is a recurrent disc in the right side, L4, L5. So we did the same technique, approach to hit the lamina. Then there was no lamina at all. And then we went to the facet, remove a bit of the facet in the medial aspect. There are huge disc, lot of disc material has come out, and the patient got relief 100% after the surgery. So this is the before, and this is the next day morning. And the same patient came to me after 7 years. I did the MRI and the X-ray both. The patient was very much comfortable and without holding the sidebar also. Now this is another publication for the recurrent disc. Now come to the foraminal, extraforaminal disc or the far lateral disc. As you know, this is a central, paracentral, foraminal and extraforaminal. But in extraforaminal disc, you will have get the excruciating or intractable pain, severe pain. Now here is a patient of a 3-level disc, 41 years volleyball player. Left side, there is a thigh atrophy, and this is 8 months history, 3, 4, 4, 5, 5 S1, all the 3-level disc. This is a 3, 4, 3, 4 is the extraforaminal. 3, 4 is the extraforaminal, and 4, 5 is the foraminal, and 5 S1 is the central disc. So one patient, 3 variety of disc. I have given a mark with the spatial localizing device, 4, 5, 5 S1. But 3-4, it is not an interlaminar approach. It is a direct duct of the isthmus or maybe pars. So it is a extraforaminal, direct foraminal approach or extraforaminal approach. So marking will be little bit cranial, maybe it is 5 millimeter cranial. So accordingly I marked here in the foramen, at the top of the foramen, not interlaminar, it is in foramen. So duct instrument, same technique, just 5 to 10 millimeter cranial. Short video, you will enjoy this. So duct the instrument here, then remove. This is a left approach. L3, L4. This is the intertransverse ligament. This is the cranial nerve root here. My petty is protecting the nerve root, and the caudal is the disc. So always the cranial is the nerve root and caudal is the disc here. This is not the traversing nerve root. This is the exciting nerve root. So the cranial will be the nerve root. 3 level, we have operated all the 3 level. Now this is another technique where I preserve the ligamentum flavum. Superficial layer removed, young man 32 years, huge disc. So with the help of the angle of the Carisian punch, I detach the both cranial and caudally, the deep layer of the ligamentum flavum, and with the help of the 11 number blade, midline separations of the both the ligamentum flavum, retracted and as a flap, intact laterally, remove the disc, and then keeping back that flap. So preservation of the flavum. This is the 3D endospine system I'm using for 2.5 years. January 8th, 2022. I started the 3D endospine endovision system of this torch. And I'm also doing the same type of, Rohidas is doing the 3 days course of 3D endospine. This will be on August 2024, 16 to 18 at my place, Bhubaneswar. I have given a permission to continue the same, one more my next talk. Can I? Or any question here? Then I can go to my next talk.
Sorry, but very nice, excellent technique. Okay, but what's the difference from micro endoscopy, MED technique? What's the difference your technique and micro MED technique? What's the difference?
This is a mobile. This is a mobile unit. You can mobilize maybe 2 level also 4-5 person can be decompressed and also bilateral left right approach from the left side and go to the opposite side. And 4-5 is one. It is very difficult to mobilize immediately within a fraction of second a microscope, but it is a mobile technique.
No. Micro endoscopic technique, MED, micro endoscopic decompression. Not using a
the concept of the concept of the micro endoscopic, I don't know how you are using the endoscope in microscope. I don't know.
The endoscope, tubular inside the endoscope.
So there is a tubular endoscopic. That is not micro endoscopic.
No. They call the micro endoscope technique.
I don't know. I know there's a misnomer. I think there is no microscope at all.
There is tube and put an endoscope and
do
like this.
Okay. Yeah. Same technique. There is no microscope, only endoscope. Can I go for the next talk?
Yes, sir.
Yes. So this is the adjacent segment disease, endoscopic management. 79 years, almost 79 plus 80 years man complains of the severe pain, and this is the upper thigh and the buttock pain, that is the radicular pain for last 3 years due to the severe stenosis. He has undergone the surgery 3445, that fixation about 2007, and he came to me with this stage. This is the 2-3. This is the 2-3 stenosis. 2-3. So 3445 is fixed. 2-3 stenosis. So without disturbing the fixation and without extending the fixation, this was the situation of the patient. Severe agonizing pain, not able to walk beyond 2 to 3 steps. And this is my dock of the instrument here. This is the destined tube and localizing device. And keeping this intact or without disturbing the fixation device, and without extending the fixation device or decompression, this is a small video. There are a lot of fibrosis. The instrument was visible, but it is a mobile technique. So we have decompressed removed the all fibrous tissue, and then went inside and removed the ligamentum flavum, that was hypertrophy, and this was the bone. This is a osteophyte. Now went to the opposite side, and we did the decompression, nerve decompression, and also foraminotomy of the opposite side. Next day morning. Now 52 years lady, fixation 2010. After 7 years, adjacent level, the disc, huge disc at L5S1, and this is the right side disc. Small video. First bite at the spinal ulnar junction. So adjust, this is a huge osteophyte from the facet. This is a nerve root. In between the dura and the nerve root, there is a huge axillary disc, and it was a bit adherent. We removed the in toto, and then went to the disc content area. There was a free fragment, irrigation with the normal saline and gentamicin. I regularly do that. So next day morning, 33 years male, undergone 4-5 discectomy and TLIF 8 months back. And this was, I think, last week I operated. There was no relief after this surgery, severe pain, right radicular pain, scoliosis, unable to stand beyond 4 to 5 minutes, unable to walk beyond 10 to 15 steps. So he was having the pain for last 2 years. In 2022, he did the MRI. 2023, the second MRI before the index surgery. And this is my surgery after the open surgery. So you can see the scar, the open surgery, 4-5, and discectomy with the fusion. I don't know why there is a fusion, but there is no listhesis, no nothing. MRI was, X-ray was, everything is fine. But somebody has done it. Then 3-4, there was a disc. In 2024, this 14, about 3 weeks before, he came to me. In 27th, I operated him. Scoliosis, few steps he was able to walk. Pain, this was the MRI. The 2-3, 3-4, sorry, 4-5 is operated. Now 3-4, there is a disc with stenosis. 3-4, there is a disc with stenosis, this area. So this is the implants or the metals. Keeping the metal intact without disturbing that, I use the drill first. This is the 3-4 level right approach. So this is the cranial, caudal, midline, and lateral. This is right approach. This is the lamina, and this is the facet. Lamina is here, facet is here, midline is here, and the caudal is here. So a lot of fibrosis, because 3D camera, so depth perception is good. And it is easy to handle. You can save a lot of time. So this is the disc. There are a lot of discs also, but it was a bit tight due to fibrosis. So it mobilized. Then I removed the disc. So this is a scar here, open and the endoscopic. The operative technique is the same. And I'm putting the patient in the knee chest position on the bolster. It takes about 40 to 50 seconds to me, because I'm doing in the same for last 17 years. I started the endoscopic career in 2007, August. And I'm putting the C-arm in the lateral position. No need to take the up view here. So another patient, say 70 years, 69 plus, is a doctor, surgeon. There was twice operated. First is L4, L5, then extended the implants, everything, then fixation device, 3-4. So twice operated. Second surgery shows the discharge summary shows there is a bilateral nerve root injury. There is a dural tear. And patient came to me after 2 years of this surgery with a severe pain and agonizing pain and the cauda equina syndrome. He was begging for this surgery, and there was a 2 level above and one level below stenosis. Severe stenosis L1, L2, L2, L3, 3, 4, 4, 5 is already operated, and 5S1 also there is a severe stenosis. So all the 3 level we have taken up, that is L1, L2, L2, L3, and L5S1. Bilateral decompression with the help of this is 3 level we have marked. All the 3 level we have operated. Next day morning, patient is pain-free, can walk with the axillary crotch because bilateral foot drop was there for last 2 years. And Kodai-Guna syndrome, severe pain, burning sensation, everything relieved. So my endospine journey, around 3,000 cases for 17 years. Thank you.
Thank you, sir. Any questions? Now next talk, Dr. Abhay Nene. He's a senior spine surgeon in Mumbai.
So thank you for having me in this very august gathering of extremely talented surgeons. And I must confess, full disclosure, that I don't do any endoscopic surgery. So what I'm going to talk here probably is foreign to many of y'all. But I think I'm going to zoom out of the endoscope and give you a view of what a general spine surgeon looks upon when he treats disc diseases. And I think that kind of grounds all of us, because many of us don't have the hand skills that you guys have. So we need to still continue doing surgeries. And this is how we look at, from our lens, this is how we look at disc disease. And I'm thankful that the organizers have included me. I feel like a pigeon amongst the cats, but I still have to do my bit. So I'm going to talk to you about the variety of options that, as a general spine surgeon, I would use to treat lumbar disc disease. As you know, mostly lumbar disc disease is a conservable phenomenon. So if you see the plethora of cases that come to you, they come in a variety of situations, and these are all my cases. If you see the one at the bottom, we did a interlaminar discectomy and decompression. The next one, which looked pretty similar otherwise, we did a microdiscectomy. Another one was actually pliffed, and this last one was actually conserved. So when you have so many options, it does get confusing as to which option to apply to which scenario. And I'm here to try and join the dots from the view of a non-endoscopic surgeon. So here's the first scenario, which is the commonest scenario that I see in my practice, which is an urban spine surgery practice, general spine surgery practice. It's the regular office goer with back pain, and his back pain is of mechanical origin. So he sits for long and he gets back pain. When he does, an excessive outdoor activity, he gets back pain. Otherwise, he's fine. And this is a non-radicular back pain. So we must understand that the source of this back pain is the instability, which means that this gentleman has a degenerated disc. And if you look at the cascade of degeneration described by Farfan many, many years ago, and that elegant diagram by my boss, Dr. Bhojraj, you will see that that phase of instability is where many of us are stuck, where the disc has dehydrated, it's lost its shape memory, but it's not lost its mass and its ability to move. So a hypermobile disc is actually the cause of the pain. And this person actually just needs rehabilitation. So if you can properly convince him about what the cause of or counsel him rather as to what the cause of his pain is, and then add alternative mechanisms of load bearing, because the disc is a avascular item. It's an avascular part of the body, so it has no scope of regeneration. While your muscle is probably the only tissue in your musculoskeletal system that can actually regenerate. So if he invests in his muscles and they become the springs that can take care of the weak disc, then that's sorted. The next is a patient who comes with a radiculopathy. So someone with a disc prolapse and radiculopathy, whatever the size of the disc, remember, leg pain is not a physical phenomenon, it's a chemical phenomenon, which means inflammation causes pain. and compression actually causes paresthesia. So a lot of us get hoodwinked by the size of the disc, and we look at the severe compression and say, oh, if the pain is so high, I need to do discectomy. That's not true, because it's an inflammatory reaction of the nerve root, which means that the nucleus is not recognized by our immune system because it's kept away from the immune system. And when it leaks out, there's an immune reaction, and all you need to do is wait it out. So in the light of no deficit, please don't jump and offer surgery just because you can do them. You normally wait it out, and if you wait long enough, you actually even see, results on the MRI scan. So these are all conserved patients, and I must confess that in my practice, I conserve about 85% of lumbar disc prolapses with great clinical, clinical and radiological outcomes, and they are your happiest patients. They become your torchbearers and advertisements. So though you're a spine surgeon, in a clinical setting, you become a spine physician. Now, if your patient is a very high demand patient who can't handle his leg pain, then of course you have the right to push nature. And once again, remember, the fragment is not the problem. The inflammation is the problem. So all you need to do is put in an anti-inflammatory medicine there, and that's a selective nerve root injection. And again, this has a very high success rate. So all I'm trying to say is just because we have great gizmos to do surgery, don't lose sight of reality. And please do continue to do what is correct. Now, if this person, this person actually could actually have an endoscopic surgery, in my opinion. So if you wanted to push the limit here, then this is a good case for endoscopy from a non-endoscopic surgeon's opinion. What about this guy? Now he is pushing the bar because he has leg pain, radiculopathy, and a large disc, and potential neurology, like an EHL of 3/5, anti-gravity power still restored, potential neurology. Here you could do an interlaminar discectomy, which could be endoscopic or microscopic. In my hands, I do a microscopic discectomy, and normally, again, as an outsider, I'm going to say that I've not had a problem with it, so I'm not looking for a solution, and that's the reason I've not changed. So I don't want to look for for a solution when there's no problem. A case like this, which is a more lateral disc, I think would be best approached through a transforaminal approach, which you guys do elegantly. We make this a bit messy because we get under the facet and then we end up taking out a lot of bone. So if I approach this disc from the way I do it, I may end up taking out too much bone. And here I would call my colleague and have a transforaminal endoscopy. A sequestrated and migrated disc. I saw Dr. Day showing some great cases, but I have seen more, I'm going to say screw-ups with endoscopy. And I'm going to say that if you want to do endoscopy here, you should be a skilled endoscopic surgeon. And otherwise, you just go and do an open or a microsurgery and go looking for that fragment. Because this is one case where, an endoscopy was attempted and there was nothing done. The disc was left behind. And here's another case. So I've had like a half a dozen cases of sequestrated disc, possibly done by a less skilled or less experienced endoscopic surgeon. But my takeaway is that you need to be an experienced endoscopic surgeon to do this endoscopically. Otherwise, I'd rather go looking for that fragment and take it down. While these ones are the real traps, if these are hard central discs with long-standing symptoms, presenting like canal stenosis with a new radiculopathy, and you see a hard black disc, you're going to have a hard time doing this in any other way except using an osteotome. So here, I'm going to do a wide interlaminar window, use a 5 mm osteotome or a ultrasonic chisel, and take this disc down. And that's the only way that this is going to actually have a long-term, long-term lasting result. A far lateral disc, which is another situation where a patient comes with lancinating pain because it's hitting the ganglion. His thigh is on fire. And this person, again, I think does as well with an endoscopic approach because you go you go through the muscles. If we have to do it, non-endoscopic surgeons, we would do a Wilsey approach, which is a bit of a damaging approach because you're going, dissecting through the muscles, a bit bloody, and it requires some skill sets because you need to expose the transverse process. You need to identify the ganglion and take the disc fragment out. I think you guys do this more elegantly than us. So that's as far as the, the far lateral disc is concerned. If there's a lumbar canal stenosis and this person has a disc extrusion, I would offer him, again, conventional surgery rather than an endoscopic surgery. But I just saw some of you, and I saw Ashwin's presentations where you all do a good, foraminotomy using endoscope also. I think Shailesh is going to talk to us about it. So I think things have changed since this lecture was made. But my only, my only plea is that laminectomy is not the surgery for this patient. When you do a laminectomy, you still leave back the foramen untouched. So you need to go down and de-roof the foramen, and that's what you want to do. And we normally drive an osteotome and take that down. And unless you, take away that lateral recess roof, you're not going to give him a result. And if you leave him with a laminectomy, he's not going to be a happy guy. And then this guy, a guy who's a very high demand athlete of a variety of resources, who comes with a tall disc. A tall disc which is centrally prolapsed is an unstable situation. You see modic changes at the end. If you have fluid in the facet, vertical facets, all these guys with a high demand back, I normally offer them primary fusion. And some of the covert signs of instability in a disc are a tall disc, potential lumbar canal stenosis where you need to take down a lot of bone, and of course wet and vertical facets. You get them to do dynamic x-rays, and they will have a poorer result if you only decompress them rather than fuse them. So when you fuse these guys, you aim at converting a dysfunctionally painful mobile segment into a painless immobile segment. Like in this guy, most of you know this guy. He's the West Indian opener who slayed us in the World Cup. And we had been treating him for a very, very long time until the pain kept coming back. So it's a high demand back, and just a fusion surgery got him back to full all the antiques on the field he could do. Similar to this, again, well-known ATP player with he had a disc which was an unstable disc, and the surgeon at 2 occasions just did a decompression, and he was unhappy. And we did this little biggish surgery at the turn of the century. This is like 2005. And he came back ripping strong. So basically, if you identify a high demand back, you want to give him a high demand surgery and not do not to pussyfoot around and just decompress the nerve roots. What about these difficult situations which come a couple of times in a year in your practice? So again, a high demand back, young, healthy male with multiple level stenosis and discs. Here, it becomes hard to do a long fusion. It becomes too little to just do a decompression. And here, we end up doing these soft stabilization techniques. So my message to all you MIS surgeons is don't be MIS surgeons. Be surgeons with the skill sets of doing MIS surgery. Don't look at everything through an endoscope. Zoom out, look at the big picture, and make your surgery patient or pathology specific rather than skill set specific. Thank you.
Thank you, Dr. Ahmed. Any questions? Next, we concluding this session, and we start another session. And I request Dr. Mastao Tanaka to come on the stage.
Hello, good evening. We are starting session 8. Dr. Mohindra Kaushal, sir. Dr. Sutipas. Dr. Sutipas here. Okay. I'll invite Dr. Kaushal, sir, and Dr. Masato. Please continue the session 8.
Okay, first presenter is Dr. Ahmed. His topic is mentorship versus friendship, fellowship, perspective from surgeon to join endoscopic spine surgery. Dr. Ahmed, could you start your presentation?
Okay, good afternoon. I'm Ahmed, spine surgeon from Iraq, chairperson of Spine Iraq. I'm presenting today the mentorship versus fellowship, a perspective from surgeon to join endoscopic spine surgery. So this is an academic presentation. Away maybe from you presented a lot of surgeries today. So let's go deep in academy little bit. This is my declaration. So the learning objective from this presentation is to measure the skill on a scale of time to produce a qualified surgeon. Design a new program for fellows and the junior surgeon for fast and productive learning in a spine career. So I put myself as an example in this presentation to show which is more benefit of fellowship or mentorship. Orthopedic spine surgery in Iraq, spine surgery in Iraq can be done by orthopedic and neurosurgeon as well. Career depend on luck. If you're a professor doing arthroplasty, you will be arthroplasty surgeon. If you're a professor doing spine surgery, you may be a spine surgeon, and so on. So it depends on self-effort. If you like spine surgery and your professor do not do spine surgery, you have to do something for yourself. So this is an example of my postgraduate thesis. It was about knee replacement, and I was very expert in knee replacement and revision knee replacement, but unfortunately I give up and transfer for spine surgery according to the mentorship I will describe. So fellowship, if you go to the dictionary, you see that fellowship is the community of interest, activity, feeling, or experience. On academic definition of fellowship, fellowship demonstrates a personal and institutional commitment to professionalism in learning and teaching in higher education. But mentorship, something is different. Mentorship, which we need all to do. It is the activity of giving a younger or less experienced person help and advice over a period of time, especially at work or school. Today, the term mentor applies to be involved in dynamic reciprocal relationship that is aimed at promoting the development of both experienced and experienced individuals and the beginner. On a research in the United States of over 1,000 residents, a common question has been asked to them: do you have a mentor who genuinely care about you and your career? So this is the important. We need to do the business of a spine surgery. So spine surgery is not only a science, it's also a career in the future. We need to do work to live. So they measure the association of mentorship with education and wellness. Education means the clinical and operative autonomy, and wellness is the career satisfaction, burnout, thoughts of attrition, and suicidability. And unfortunately, 1/3 of those residents reported lack of meaningful mentorship. And this is the article published in JAMA in April 2024. So there is a function of the mentor. So what is the function of the mentor? He is model for the mentee, and mentors also perform function of a teacher, counselor, guide, and sponsor. And he should give career support and psychological support. After this functioning mentorship, both the mentor and the mentee will have the benefit. Mentoring is a complex relationship requiring significant time commitment and emotional investment. This is the important part. It is the emotional investment in your mentee. This is what the mentee requiring from you to improve his career. He can do the surgery, but he can't dare to do it. He's facing the same complication you have, but unfortunately, when he faced the first complication, he may give up because he doesn't have any psychological support. So failed mentoring relationship has been occasionally described as a good life lesson. It is very painful for the mentee because he is unlucky. He has a bad mentorship relationship with his professor, so he doesn't have a benefit. This mentorship destroy his dreams. So they usually describe it as a good life lesson. This good life lesson, very painful lesson. So let's see the example. I called it my crossover, my little own Easter. I start open spine surgeries, give up. I was doing total knee replacement, hip replacement, hallux valgus surgeries. So I give up doing orthopedic surgeries and mainly do spine surgeries. Started with open surgeries, and I did early shift to endoscopic spine surgery according to my mentor advice. He told me, do not invest anymore in tubular and MIS. Go ahead, directly jump to UBE and endoscopic spine surgery. So evolution in my life has happened, and this reflected very well on my financial state as well, not only the academic or profession state. So shifting from open surgeries open surgeries to directly to the endoscopic spine surgeries. And I'm very thankful for this evolution, because I'm regarding one of the early adopters of endoscopic spine surgery in my country. For this evolution as an early adopter in my country. So this evolution in endoscopic spine surgery reflected well on my thinking about the patient and how can I do the surgery. Is it fixation? Is it or is it simple discectomy and decompression? So a few years ago, I was doing 100% open surgery. Most of them, maybe 95%, I was doing it with fixation. But on the first year of application of my new strategy of endoscopic spine surgery, I did 8% of my cases was endoscopic decompression. And in the next year, I did 36% of my work as decompression spine surgery through endoscopy alone. This also reflected on time of surgery. I started from 160 minutes in my first surgery, and over a period of 6 months, I reached about 60 minutes for each surgery, so reduction in time over about 38%. One thing I discovered during my journey in spine surgery, each spine surgery, I see that it ends twice. The first end of the of the endoscopic spine surgery was when I do the discectomy. The second end is when I stop the recording and put the drain or decide to close the wound. And I see that most of my I call this time lag. And I saw that most of my complication happened when it is, this time lag was wide. And the best result for my patient was those with the narrow time lag. And me and my friend, our mentor Ghazwan, going to do a research about this time lag during the surgeries. So this is my little journey. I started friendship with Ghazwan in 2014. Actual mentorship started 2019. Endoscopic spine mentorship started 2022. And I followed an advice from Raj Shamani, is an Indian author, one of the bestseller books in Mumbai, I think. He has a good phrase that stop innovating, start copying. So find a mentor, copy what he's what he's doing, and then you can invent. Just start. So that's what happened. This is first surgery I did with support of one of Ghazwan team as a backup surgeon.
Doctor,
And
could you summarize your presentation?
Yes, 1 minute. And then I start mentoring my fellows and teaching them. And I have mentorship through AO, and I have a mentee from Nigeria as well. So my take-home message: find a real mentor, never give up, stop copying, begin innovation, and be a real mentor. Thank you.
Thank you for your great talk. Are there any question or comment from the audience? I assume you must be a great mentor because you are chairperson of AO Spine Iraq. So, as a mentor, what is the most important thing for you as a mentor?
As a mentor, the most important thing is to take care of the mentee and teach him how to master the career, not only doing the spine surgery, how to collect the patient, how to tell them the truth and convince them to do the surgery, and how to let them believe in him. This is the most important. He can do the surgery, but sometimes he can't let the patient come. Patient not trust him. This is the most important. We should learn the new generation how to let those patients trust him, and he will do the surgery. And this is the struggle and the start of the spine surgery.
Okay, thank you. So next presenter is Dr. Mohammed. His topic is post-endoscopic spine surgery MRI, conflict to be cleared.
Good afternoon. I'm Dr. Mohammed Muzahim from Iraq. And big thanks to my mentor, Dr. Ghazwan and Dr. Malcolm, for this opportunity to present the lecture here. Post-endoscopic MRI is a conflict to be clear. To be clear, there's nothing to disclose. And should I routinely do MRI post routine endoscopic discectomy or decompression? If not, so when I have to do the MRI, which is the best time, and is there a clinical correlation between the MRI changes over a fixed interval after the surgery? And there is a review of evidence and review of our experience in the spine endoscopy. This MRI reflect how beauty the endoscopy result. This is a cervical foraminal disc, and the result after 6 weeks, only from the surgery, showing the complete clearance of the disc. Should we do a routine MRI for each post endoscopic surgery? Endoscopic surgery is only a new approach, not a new technique. So it is treat the same pathology of the spine. And still the MRI is the mainstay for detailed anatomic assessment and evaluation of the complication and decompression and fusion. In most cases, it's still the gold standard for evaluation, complication, and recurrent pain. Really, there is no strict routine MRI indication for early post-endoscopic unless there is a suspicion of complication. There is this study in 2018 showed the MRI analysis after percutaneous endoscopic discectomy and its clinical correlation. And there is a 47 patient with a lumbar disc herniation due a uniportal endoscopic discectomy. MRI was performed in the first week post-operative and in the 3-month post-operative interval. They show that there is a residual mass at the operated site was observed in more than 90% of the cases, and associated with the nerve root compression also observed in more than 70% of these cases. After 12 weeks from the surgery, these residual mass was vanished in more than 80%. And based on the result and the logistic regression analysis, there is a significant, statistically significant a correlation between the clinical symptoms and the high T2 signal intensity of the residual mass. Here is another studies in 2022 analyzed the magnetic resonance imaging and the clinical outcome in early post-operative spine endoscopy. There's 33 cases doing endoscopy. The study was finding that the early post-operative MRI and in the 3rd month and in the 12th month. Here, the residual mass after the surgery was graded and classified in 4 grade and compared with the pre-operative disc size. Grade A, there is no post-operative residual mass, and grade B, less than 25%, and grade C, 25 to 75, while the grade D is more than 75 from the pre-operative size. Post-operatively, in the 1st week and the 3rd month and in the 1 year, they watch that the grade A is 0 immediately post-operative. That reflect all the cases of the endoscopy will develop a residual mass after the surgery. While after 1 year, there is more than 90% of the cases abolished the residual mass. Regarding the grade D, which is more than 75% from the size of a preoperative disc, it is around 50% in 1st week postoperative, while 0 and over the 3rd month and 1 year follow-up. This is another study investigate the MRI after percutaneous endoscopic lumbar discectomy and their correlation with the clinical prognosis by injecting a contrast in the annulus fibrosus intraoperatively. 118 patients were included, and the contrast medium injected intraoperatively in the annulus fibrosus, and the parameter assessed is the intensity, the signal intensity T2 of the residual mass and the size of the remaining mass and the cross-sectional area of the spinal canal. A residual mass again was detected on 1 hour postoperatively in 94.6%. During 1 year follow-up, 90% of these patients display a fibrous annular remodeling, although more than 60% of those still exhibit herniation. And there is, in a multiple linear regression analysis, early postoperative ODI changes were associated with the high T2, and this is for short term. From this study, it's concluded that the residual mass observed in early postoperative MRI and short-term changes in a clinical symptom after endoscopy linked to high T2 signal intensity, while the long-term changes in the clinical symptom were associated with the changes in the size of the residual mass and the cross-sectional area. Here a case of spine endoscopy showing the annulus fibrous after the discectomy. Here there is different signal intensity of the residual mass, and in the axial section A, there is a high T2 signal intensity, while it will be intermediate, and in the C, it is low signal intensity. This is one of example of case with a preoperative disc, and in B, there is a T1 showing the ruptured annulus fibrous and residual mass immediately postoperatively, while in C and D, this is complete resolution of the residual mass over the 6 month and 1 year postoperatively. This is another case, show residual mass immediately postoperatively, and after 6 months and 1 year, this is complete resolution of the residual mass. And those 3 topics related to the endoscopic discectomy for disc herniation. This is study in 2021. This is investigate the early result of full endoscopic decompression of lumbar central canal stenosis by outside-in technique. 32 patient. This is 32 patient with the 43 level monoportal endoscopic technique using ULBD. Many parameters were assessed in this study, but we are stuck only to the MRI. They use MRI and CT scan and dynamic lumbar study for the MRI changes, and CT scan for the facet preservation, and dynamic lumbar study for the restoration of lumbar lordosis. MRI assessment for a cross-sectional area of index level and one level above and level below to assess for adjacent segment disease. So here the MRI result only preoperatively and postoperatively immediately and over 1 year. There is a significant improvement in cross-sectional area and around 200% increment in the cross-sectional area. What's amazing is the one level above and one level below over these follow-up up to 1 year, there is no changes in the cross-sectional area, and this is reflected that the ULBD techniques doesn't accelerate the adjacent segment disease. And this is an example of pre-op and post-op and 1 year follow-up. This is another study using a biportal endoscopy, and for ULBD, it's 81 consecutive patients with degenerative lumbar canal stenosis treated by 2080 to 2090. It's a retrospective studies, investigate 105 level. They check the parameter MRI study before the surgery and 3 months after the surgery. The measurement of a cross-sectional dural area immediately post-operative and 3 months after the surgery, and after 1 year, there is no significant changes in between. And that's mean the cross-sectional area can be assessed in any times post-endoscopic decompression. Our cases, this is case with posterolateral disc herniation, and after doing UBE decompression, 3 months post-operatively, showing a very grade A or grade B, very small residual disc and very good result with decompression. This is a second case, preoperative disc, and after 3 months, disc showing complete resolution of the residual disc. Take-home message, there is no routine post-operative MRI after endoscopic decompression unless it is indicated. A residual mass on early post-operative MRI after endoscopy is a common, and 3 month post-operative is the best time for MRI evaluation if there are no clinical suspicion of complication. For spinal stenosis, any post-op MRI will show the favorable result, and thank you.
Thank you for your great talk. Now it's open for discussion. Any comment, question? So before surgery, one question. Sorry, Mohammed, one question from me. So before surgery, we need MRI. But after surgery, if the patient symptoms disappear, patient don't want to get the MRI. How do you convince the patient to get the MRI post-op?
If the patient have no complication.
No symptom. Yes. No symptom. Patient has no merit to take MRI. So sometimes patient refuse to take MRI. It's costly. So how do you convince the patient? Or you seldom, you never take MRI?
Really, in our cases, we are not recommended early post-operative MRI unless at the beginnings, after 6 weeks, we send patient for MRI to assess the result of the surgery, even he's satisfied from clinically. And now, after after review of evidence, the best time is 3 months, and the more than 90% resolution of residual disc after 1 year. And I think it's a matter of insurance and the regulation of the countries. I think in Korea there is obligatory post-operative MRI for documentation. In my country there is no routine MRI post endoscopic decompression or even after the conventional surgery.
Okay, thank you.
So I think nice presentation by Dr. Muhammad. I think this is very, very important topic, but at times you have done a good job. Patient is very happy for 2 weeks or so, and then he comes back to you for with same symptoms what he had pre-operatively. And there is a situation where patient is suspecting that you do a MRI, whether that was a residual, as you said, there is a residual disc there, or it is a recurrence. So at times you are in a very surgeon is in a very difficult situation to convince the patient whether surgeon did the adequate job in the first place, or he did the inadequate job and patient has, after initial recovery, he had a problem again. So how do you convince such patients?
Sorry, only in case of suspicion of complication, I will send the patient for MRI. How to convince him? There is a fixed interval for follow-up visit post-operative. And this is different from surgeon to surgeon, but if I have a suspicion, I will send patient immediately for MRI. And this is not so costly in my country. And really, this is not a big issues.
Dr. Hassan, you want to clarify it? Yeah, my question was, you had done a good job, patient is very happy. After 2 weeks, he comes back to you with the same preoperative radicular pain and you do a MRI. On MRI, you are convinced that it is not a residual disc, but there is something residual, what you were mentioning, which disappears at 6 weeks' time. How do you convince such patients? Patient is maybe thinking that doctor has done an inadequate job. How do you manage such patients?
I think in such way, first of all, is the septum disappear post-operatively. That's mean I did my job. And I already discussed with the patient that there is a risk of recurrent disc. So I will conclude with him that there is no, let's say we are in the gray line. There is no black and white that we can conclude this is a residual versus recurrent. So if the septum persists, we can do a trial of injection. If he get benefit, okay. Otherwise, there is a chance for revision. But the problem that's, in my country, we face it because of, let's say, some open surgeon, they start to send the patient of endoscopic spine surgery to MRI, and they start to tell them that, oh, this is the same disc and nothing done. But fortunately, we have the recording video for each cases, so we start to give the patient the record, so to go anywhere to show them the work that we did.
Dr. Rohida sir, aap bataiye.
If the patient has pain in the post-operative period, he will not tell you. He'll get the MRI done and then come to you.
So my question was, he is happy for
There
15
is
days.
no point
then
in
he develops the
convincing him.
radicular symptoms. That's what my question is.
He will get the MRI and come to you.
So, okay. Now we have Dr. Nugroho. This is how you pronounce.
Yes.
He will be speaking on my transition to full endoscopic spine surgery. So over to Dr. Nugroho.
Thank you, everybody. My name is Nugroho. I'm from Indonesia. Okay. You all know Indonesia. I'm not from Jakarta. I'm from North Borneo, very 1,013 kilometers from Jakarta. This is a good place to holiday, but not good place to start to endoscopic surgery, actually. Why endoscopic surgery? I practiced for 3 years before doing open and macroscopic. I learned in Japan during my residency, and then I think microscope is still good as equivalent with the tubular. I don't need endoscopy, but some YouTube presentation caught my attention, and then some tourists from Korea and China come to visit my island, and then I see only 1 centimeter wounds, and then I'm very keen to learn the endoscopic surgery. And then, but my challenge is no other surgeon was performing endoscopy in my island. There's no distributor and representative would go to my little island. Lots of hospital administrative tape, where I go to learn straight abroad, or I go to the capital. Funding initial purchase equipment, and then how about the national insurance approval? And then fellowship time in Indonesia, we usually use 1 year. The first 6 months, usually open surgery, and then the second 6 months, I'm able to learn from the Dr. Lutfi and my senior Rizky and Harman. And doing the first time about using this video, Dr. Lutfi is filming, and beside me, usually there's Risky. But actually, after in the weekend, I go back to my hospital, and then I try to do endoscopy, and then all I have is a red black tape, and then very stressful, yeah, because it's not so easy. Because and then I only practice in my hospital only once a week, and then in the first 3 months I try to do OB with the arthroscopic fusion, and then congrats to me, I do only successful 2 times during 3 months attempt, because in my hospital they they only allow 3 hours surgery time, and then you try 3 hours. After that, you switch to open. And then after I do a UBE, I put slice, and then I put my tuber as usual. And then after fellowship time, I more actively find more potential patient, a more straightforward pathology. I contact to my senior, Dr. Harman, Dr. Rizky, and then always review the imaging with the senior and mentors in Jakarta, and then educate patient about the advantage. I see this is a new tech, but I still learning. Do you want to try this new technique or not? And then try to train some personnel. After open surgery, and Dr. Lutfi was very kind to give this tandur to try to the MED for a while, and then I tried to do UBE, and then and after that interlaminar and also transforaminal. Okay, and then Dr. Harman also, my senior, always helped me say, please find, you stick to the 5S1, and then only doing that for 1 month or 2 months, as he say. Okay, I do like that, and then this is my times. I think scope time is the best teacher. If you doing it alone without any mentor and without any teacher around you, I do usually L5S1 first, and then after the time is decreasing, I do for the 4 and the 5, and then after that I do the migrated disc. After the time is less than 1 hour, and then I try to do a fusion, but it's happened nightmare, and then I stop. I don't do fusion again, and then after that there's a COVID time. Still, we have only, this is my first, you usually use UBE, and then after the end of the year, the interlaminar comes, and then I do still so many complications, no improvement like this. And then the second COVID time, I try the interlaminar and transforaminal. I usually watch Dr. Partoji YouTube, and then I do fusion surgery also, but it came out no fusion, and then I stopped doing fusion with UBE, and then after last year I went to Dr. Pau to learn how about the endofusion, because in my country endofusion is not so familiar even, and then this is I'm trying to do, like this is the original Dr. Pau, and then it's not quite the same, because like doctor from Iraq say, copying is also hard. Dr. Pau use it good, but it's not so good. It's very hard. But using no punch technique makes more time, and maybe I need more scope time. And then I do always try to adopt the new things also in my country, in my hospital, which is a border. We always have many drug traffickers get shot by the border patrol, and we can do full endoscopic surgery removal. by using uniportal. And then also we can use the biportal. It's according, when we use biportal, we use it if the shotgun is like the pistol, according to, because if we use uniportal, it will not match the cannula. And then we also have tried to adopt new things using endoscopy by treatment of the thoracic tuberculosis. We can, so at first I do like Dr. Henry from the Philippines, but using UBE for the debridement of the TB. But when we take out the phlegm of the TB patient, sometimes the kyphotic more happen, and then I stopped doing UB for the POTS disease, and then I doing FATS for the TB. It's also endoscope. Some the thoracic guy say, "This, are you allowed to do this?" I say, "This is UBE." And then we can do a lot of with using thoracic surgery. And then my take-home message is, it doesn't matter where you work in your country, whether in your capital or in the border, we can learn endoscopy. Choose your patient very carefully, engage in many discussion, seminar, keep in touch with your teacher, your senior. I always call Dr. Lutfi, Dr. Yuda, Dr. Harman, even in I'm get lost in the operation. And also I contact my abroad teacher, Dr. Pao, attend a cadaveric workshop for training, and after visitation to another hospital. The most important is to take your time in the OR. Every step needs more time, and also increase level of complexity as your skill improve. Pay attention to your technical milestone, such as do the lumbar first, then the cervical, then thoracic. Then this is a very interesting journey. We have plenty enjoy style to learn from the every part of the world. Thank you very much.
So, Dr. Nugro, you have tried hands on many endoscopic techniques. Finally, which technique you have mastered now? You tried the Stendu also, you tried PSLD also, you tried UV also. Which technique you are now doing nowadays?
Now I do UV.
So you are finally, you are in love with UV. Chalo, great. Any question from the house? So we have another speaker, Dr. Gajwan Hassan. Dr. Gajwan, as I know, he is an experienced endoscopic spine surgeon from Iraq, and he will be speaking on endotelif technique and limitations, our experience. Over to Dr. Hassan.
Thank you all. Giving lecture at 7 p.m. and in the program starting at 9 p.m. I don't think it's an easy job. So I would like to thank you all. Thank you, the moderator, and Postenji, Anand Kavi, and all of them to stay till 7 p.m. to listen my talk.
Malcolm, you should get beer and wine here only now.
And I think that we will go directly to the gala dinner without any even changing our clothes. So, endotelif technique, it's not a new, this is my disclosure, nothing related. Imagine every year in US, they are doing more than 300,000 cases of spinal fusion, which is, and this will reflect the market on the US when it's compared to the other area. And US is the market for implant and spinal fusion. And the good news that the American companies started to invest in the endoscopic spine, and Arthrex, they built their own system. So I think that from my perspective, the next coming years will show the difference in the endoscopic spine surgery, at least in North America. These are my learning objective. And I think that we heard in the last 2 days about how can we mastering the technique and starting to do more and more cases. These are my experience that I started with disc prolapse, stenosis, synovial cyst, recurrent disc, ASD, spondylodiscitis, and finally for endotelif, and right now to do more than one level. And the area that's the endoscopic spine fusion, it's not a new, it's started in the 1997. And the good thing that they have a very good, let's say, a preparation of the end plate and the fusion rate that you can imagine in some paper up to 100%. And these are the view that we will see later on. And actually, the endoscopic or MIS fusion, they are classified as air-based and water-based. The air-based, as we know, that's in the MIS T-lift, O-lift, X-lift, and other. And the water-based is it's by endoscope, whether it is biportal or uniportal. And these are the abbreviation, that's the approaches that are used for the both uniportal and biportal, and I can summarize it that it can be used by interlaminar, transcambian, and even dorsal approaches, as some authors and of you that's explained. And to summarize it, by the technique we have uniportal, biportal. By approaches we have interlaminar, facet preserving, which is called transcambian, or facet sacrificing, which is called transforaminal. Lateral approaches, and even we know that's the master of the double cages, Professor Bo from Thailand, who used the double cages. So I put this as a single versus double cages. These are the technique. I will not go for it, but I prefer to do it by UBE because for many reasons, one of them, it's an extension from my technique that I started to do, let's say, TLIF in the open, then MIS, then I shifted to the UBE technique. And actually, we are coming from Iraq. We are not a rich company. We are not living in US. So mastering and making the availability of the instrument is a big issue. So for me, I'm using the basic instruments for the open and MIS to be applied for the UBE technique. And also the easier learning curve, as you see in some literature, which is 24 cases, although my fellow, they start to do the UBE in less cases. And the good thing that it's over direct and indirect decompression. I came from an open technique and to MIS, so it's still, for me, it's difficult to convince myself in the indirect decompression, although I started to do some, let's say, olive technique, but this is another advantage. And using the same instrument for the basic, as I mentioned, and also it's different approaches. It's depend on the pathology that I have. So these are the 10 steps that I follow to do the endoscopic TLIF. The first is the indication and the review of the cases. These are the X-ray, spondylolisthesis, L3-4, which is straightforward cases. These are the MRI. So these are the ideal indication for me to start it. There are many, let's say, experts of you may agree or not about the positioning of the skin. Professor Postenji said that I put it in the let's say spinous process. I used to use it medial because my aim is to target the spinal canal and then going from the lateral. It takes time, but for me it's offer both direct and indirect decompression. The first step that I have to create, let's say, the spaces that's to do the work, and the best thing that's to identify the joint, and after that to proceed with the next step. And these are after identification, I started to do fascectomy, which is, I think that is the same procedure that's done under local. I prefer to use the osteotomy over the, let's say, high-speed drill in order to preserve the bone to be used for the fusion. And next step, ULBD, in case that is indicated or not. In some cases, I don't use it when it's not indicated, but in other cases, when I need a decompression, I use it regularly. And then after that, I have to identify my space in order to proceed with the discectomy. And the exploration of the exiting nerve root is not always for me indicated, but if I check it, okay, otherwise I can proceed with the space. And then the beauty of the endoscopic spine surgery is to see the disc space, which is, I think this is a huge advantage when it's compared with the open technique. I don't think that's no one do this technique when they are using the open technique. So this is a great message to the guys who not believe in the endoscopic fusion, because I think that's the fusion rate will be at least similar or much more than compared with the open technique. These are the technique that I'm using for bony graft. Almost it's, let's say, auto harvested bony graft when it is sufficient, okay. When it is not, I'm using allograft. At least 8 to 12 mil of bone graft to be used. And this is the final step. That's when I use the bone graft to insert it. The expandable cage for me is a good option because it's inserted as a small cage, so I can expand it and fix it accordingly. And these are the final view, that's endoscopic view, that I can see everything is okay, and then shift it to percutaneous fixation. And these are the couple of cases that I did. So I think that's, for me, don't resist. Think about Kodak, BlackBerry, and I think that the open surgery will be gone. Thank you.
Nice, Dr. Hassan. Beautiful talk to the point, and I think we have still time. You have another talk or only one talk?
No.
Sir has a question to
So I have in time.
Yeah. You are very well in time.
Yeah.
This is an endoscopic meeting. I shouldn't ask this question to you.
Okay.
But I perform lateral approach. So if you choose lateral approach, it's very big corridor there. And then we don't have to remove any bone. So, and it's about 1 hour surgery. That case, you don't have to decompress. Indirect decompression, it works very well. So why you do this kind of complicated technique?
I'm doing both a technique actually.
Yes,
I'm doing
why you do both?
This is the case that I did about 2 years ago. But right now, if the same case come to me, I will do olive for.
Okay, thank you.
Yeah, I'm honest with you, because this is a straightforward case for olive surgery to be done, especially for the beginner. Yeah. Yeah, I know.
OLIF, ALIF, and XLIF.
Yeah.
These surgeries come with a lot of caveats. First caveat is that the patient, after lying down, should have 50% reduction in his back pain. He should not have central canal stenosis. He should not have lateral canal stenosis. He should not have a free migrated herniated fragment. Now, you don't get this kind of cases with all these caveats all the time. Sometimes you have a patient with an up-migrated fragment with lysis listhesis, or you have an adjacent disease where you have to do a fusion extension with a migration, and you can't go for OLIF or ALIF or XLIF. So you need to have something in your armamentarium that overcomes these limitations, and UB is that surgery which has no limitations.
This is the good thing, that I agree with the Professor Tanaka that some cases you can do an olive, okay, but not all cases that can be done with olive.
So you have to be
while all cases can be done by UB.
Precisely, but that does not mean you do all by UB. It still means you do OLIF, ALIF, XLIF,
so olive
if you want to do it.
Yeah, thank you.
Malcolm, next time you have a debate, olive versus UB.
I'd love it.
Next year. So, thank you very much, speakers. We conclude this session and over to Dr. Kiran for next. He will be coordinating next section. Thank you.
Thank you, sir. I call upon for chairperson Dr. Srinivas Rohidas, Dr. Pishi De, Dr. Harshad Parekh is there. Okay. And I call Dr. Saishav Shah. Then Dr. Namit, please prepare your talk. Get ready. Then Dr. Nadir, please come in front seat. Namit, and Nadir. After 2 talks, we'll continue with this 5. We'll make it 5. Saishav is here. Namit Natrawal is there. He's preparing. Then Dr. Nadir is there. If not, then Dr. Sailesh, then Dr. Asif. Done. ये आपको मैं दे रहा हूँ, बता रहा हूँ.
Good evening, everyone. I am Dr. Shaishav Shah. I'll be very quick in my talk, especially we are running quite late. I'll be talking about hybrid endoscopic spine surgery. So what is hybrid endoscopic spine surgery? It is just merging of two techniques in one case. We generally don't get simple discs, simple single level stenosis. Many of the times we are landed up with multi-level stenosis and multi-level I'll show you a few cases there, how we can approach different techniques with different pathologies. So this is one case, 67-year-old female with left lower limb radiculopathy since 6 months. All conservative managements have been tried with her. She's having left EHL weakness, left L5 dermatome sensory deficit. Her leg pain is more than back pain. And this is her MRI image. So as we can see here, there is paracentral as well as extraforaminal component of the disc with ligamentum flavum hypertrophy. So for planning of this surgery, I basically am an interlaminar endoscopic surgeon with biportal. So first I'll do bilateral flavectomy and left-sided discectomy. And the other thing which I planned is, along with that, I'll do a transforaminal discectomy. So addressing this pathology both the ways. This is a short video just to show that even after completing a proper discectomy with interlaminar UBE, there was one fragment there which I found in transforaminal. So I think I'll just skip this as we are short of time. We all know what we do in UBE, right? We all know what we do in transforaminal. So this is the scar of the patient. Her POD leg pain was quite satisfactory. POD2, she was ambulatory and her pain was almost gone. One more case, 60-year-old male, left lower limb radiculopathy with claudication, EHL ankle dorsiflexion both weak, grade 4, sensory deficit, and leg pain more than back pain. So this is a multi-level L4, L5 stenosis. Sorry. Yeah, and L5SN left-sided disc with stenosis. If you can see, there is also foraminal stenosis in left-sided L5S1. L5 root is compressed for here in the foramen. So to approach this, this was done UBE. This was done UBE as well as left-sided para-UBE for extraforaminal foraminal stenosis. So this is the scar of the patient. I believe with para-UBE, this is my personal experience, with para-UBE the patients are very happy. I mean, just freeing that root, I think those patients are very, very happy. Even with their, even when there is some back pain, for the back pain as well. I don't know why, but that is there. One last case, 81. I got this series now above 80s. I've got many patients where I've done multi-level scoliotic degenerative spine, 2-level, 3-level decompression without non-fusion surgeries. So this is her history and the examination. She's having EHL weakness, L5 dermatome, leg pain more than back pain. So this is her MRI, L3, L4 stenosis, L4, L5. Her X-ray was also not that good. X-ray is also bad. L4, L5, she's having this lateral recess as well as foraminal extraforaminal compression. And L5S1, here you can see L5S1 right-sided stenosis, foraminal stenosis. So this was approached UBE for L3, L4. In this, I went over the top and decompressed the exiting root as well. And for L5S1, it was right-sided para-UBE. So this is the post-op MRI, L3, L4. You can see good decompression over here. L4, L5, there was, I went on to decompress both the roots, right-sided for L4, L5. This is L5, S1. Here we can see the foramen that has been opened up, right-sided para-UV. So for multi-level pathologies, degenerative pathologies, I think combining two techniques is never harm. We can avoid fusion surgeries in these geriatric patients, wherein we all know that fusion levels more than one are not that great outcomes. So endoscopy can definitely help us in these non-fusion surgeries. Thank you.
Very nice talk. I think we should learn this technique that the last sentence over the take-home message was very nice, that you understand the pathology of the patient. That is the key of this talk, I think. Any question? If there is a pathology of the both the central canal, then paracentral lateral canal, and also the extraforaminal, what he is doing, that para-UV also sometimes helps to relieve the pain from completely. So that is the key message. Thank you. So the next talk will be Dr. Namit. He is going to speak on the operative perspective of the UV endotelief. Dr. Namit.
Good evening. Myself, Dr. Namit Nitharwal from Jaipur. Thank you, Malcolm sir and Tau sir, for inviting me to this World Congress. As per Supreme Court of India, we are unable to broadcast live surgery. So I made this presentation for new beginners for how to perform UV endotelief step by videographic presentation. This is a case L4, L5 degenerative listhesis with stenosis. Operative step we will take one by one. These are the skin portals, one endoscopic portal, one working portal. These are the basic UV portal. We can, after getting experience, we can just lateralize the portals as per your experience. These are the skin marking in midline and medial pedicular line and at disc level. And we should also confirm our portal on lateral view, that the converging should be at our disc level or our pathology level. And this is a video demonstration of the skin incision. We can take either step incision, vertical or horizontal, as your convenience. And after making portal, we should confirm on both FE and lateral. In FE, at our starting point should be for UV decompression and discectomy spinolaminar junction. And after getting experience, you can take this point at tip of the inferior articular process for endotelief, and you should also confirm on lateral view. And now we proceed for creating a working space. First, we should do serial dilation for working portal, and after serial dilation, we should just strap the multifidus muscles from the lamina to outward, and then put another blunt dilator at the scopy portal and make them and check the movement to make a free egress of fluid. And after that, we connect the fluid and then check the free egress of the fluid from the working portal, and then use RF or plasma to control the bleeding and make the space. And then we proceed with burying. We can use either 4.5 mm or 5.5 mm conical or diamond burr, and our starting point should be if the inferior laminar junction, inferior part of the spinolaminar junction of the superior lamina. Then according to pathology and according to our procedure, we can do laminotomy, either from ipsilateral or contralateral as per need of pathology. In this case, we are doing a endothelip, so we just start to do inferior part of superior lamina and then proceed toward the inferior articular process. So after bring, we proceed to facetectomy. In this procedure, we can take either 4 mm, 5 mm or 6 mm osteotome, and then we should check the tip of the osteotome at the time of osteotomy. That should be not on dura, and ask your assistant to hammer out it and then remove with disc forceps or your small nibbler. And then rest of the decompression like same the age we are doing open spine surgery with help of the disc forceps or rongers, and then we proceed to discectomy. At the time of discectomy, ask your assistant to hold the dural retractor and then make either a stab incision or a rectangular incision with help of 15 number knife, and then remove some part of the disc, and then rest of the disc preparation will be like same as in we are doing in open surgery. Like we proceed to end plate preparation. We can use serial dilation under the direct vision of this scope. At the time, the precaution should be taken. We should not damage the insertion of the instrument, should not damage the dura. So ask your assistant to hold the dural retractor, and you should continuously stick to the scopy to the part should not be damaged, and then after serial dilation, we should proceed to a curate. So advantage of UV, we can use our conventional instruments. There is no need of special cage instrument system for this end plate preparation, and then we use rasping or superior and inferior end plate, and after rasping we can visualize the disc preparation. In open surgery, we are unable to see the disc preparation. The advantage of this UV endoscopy, we can put scope inside the disc space and then see how much we have made the end plate preparation. We can see punctate bleeding, and then accordingly prepare the end plate for fusion. And after this, we put the bone graft, that is autologous bone graft. With help of this funnel, we put bone graft, and we can take too much age required bone graft, because of we just use osteotome from make a bone from this facet. And after this, we can use cage. Advantage of this UV, we can use normal or conventional cage or some special expandable cage. In this video, I am using a simple cage like which we are using in open surgery. And precautions should be taken. We should not injure the dura at the time of cage insertion. And this is the video we showing the cage inside the disc space, and then simultaneously we confirm on the CRM. And the rest of the procedure is the same as like MIS. We are putting MIS screw and then putting rod system and then compression. And this is the post-op array. We have achieved a reduction and good decompression, and patient can be walking next day morning. And the take-home message for this procedure, UV endotelip is a safe and good fusion procedure, and we can make good end plate preparation and a direct vision, and there is no need of a special case system. Thank you.
Any question from the audience? We'll go to the next presentation by Dr. Nadir. Should I invest myself into uniportal or biportal?
Okay. Thank you. नमस्कार, गुड इवनिंग एवरीवन। ये भारत में मेरा दूसरी बार है। मैं यहाँ आकर बहुत खुश हूँ। धन्यवाद डॉक्टर माइकल। I don't know how it came out, but this is how the Algerian Hindi accent sounds like, in case you ever wondered. Should I invest myself into Uniportal or Biportal? Tricky question, isn't it? I will try to add grist to the mill, but not from a clinical perspective for a change. But first off, some disclosures. I work for these guys, and even though I'm a UBE surgeon, I promise you, I tried to be as much unbiased as I could be while preparing this presentation. World Federation of Spine Endoscopy. What does it mean? One definition is a group of separate entities which come together because they share a common goal. And from my understanding of this World Federation, our common goal is to join our minds and efforts to refine spine surgery towards less invasiveness and better results for our patients worldwide. So, it's 2024 and open, loops, tubes, and microscopes are still used in the vast majority of spine surgery. Is it bad? Of course not. Does it still work? Of course it does. Then why change? Because we still can do better. Spine endoscopy, which started in the 70s, is in its 5th decade of evolution, reaching maturity in the early 2000s for Uniportal, just when UBE started its baby steps, then thriving in Korea, thanks to Dr. and Dr. Son, until today, where it has proven its effectiveness and safety. Both techniques are outsiders, challenging the well-established gold standard techniques. Both have their advantages and shortcomings. Having said that, between Uniportal and Biportal, which is likely to take the lead in the ongoing spine surgery revolution? Time will tell, but history can teach. So let's go back in time. The first modern car was marketed in 1885, but still, 15 years later, the main transportation was still horse-powered. Then, within a decade, cars were everywhere. How did this happen? It happened with this car. The Ford Model T was an affordable, reliable, mass-produced car, and it sold like hotcakes. Affordability and cost-effectiveness are what the automobile industry was waiting for to finally phase out horsepower transportation. Another example we can use is from the video entertainment industry. In the 70s, videotapes and recorders offered consumers the ability to record and watch videos at home, challenging the traditional forms of video entertainment distribution on TV and in theaters. Videotapes came in two different competing formats. Betamax was launched on the market in 1975. VHS came a year later in 1976. A raging competition took place where Betamax had a superior image quality but was expensive, while VHS had a lesser image quality but was affordable and offered double the recording time. The rest is history. Consumers had spoken. Affordability and cost-effectiveness prevailed over expensive technical superiority. In the early 90s, a fierce competition took place where Nintendo and Sega each came up with a groundbreaking portable console, revolutionizing the video gaming industry. The Sega Game Gear was technically superior. It had a backlit color screen with over 4,000 colors, while the Game Boy had a monochromatic screen with only 4 shades of gray. with no backlight, making it impossible to use in low light setting. The technical superiority of the Game Gear was eating through 6 batteries at a time that lasted 3 hours tops, making the Game Gear both expensive to buy and to use with a cost of $2.34 per hour. On the other hand, the Game Boy was much more affordable and needed only 4 batteries that lasted 10 times longer, bringing the cost of use to only 16 cents per hour. Here again, expensive technical superiority was no match to affordability and cost effectiveness. Compared to the Game Gear, the Game Boy lasted on the market double the time and sold 10-fold units worldwide. The last example is from the photography industry. Digital photography challenged and successfully replaced traditional film photography in the 90s. To capture the image, it relied on 2 different competing sensors. CCD sensor came first on the market, later followed by CMOS sensor. CCD equipped high-end cameras because it offered a superior image quality in terms of dynamic range and low light performances, making it the ideal sensor for our surgical cameras. But CMOS was easier to integrate and far cheaper to make, which reduced the complexity of the device and its cost. So even though CCD was technically superior, the affordability of CMOS attracted the industry into further research and development. So much so that nowadays, CMOS is more efficient than CCD, even replacing it in our surgical cameras. So out of these examples, we can see that in the long run, it is often the cost-effective innovation that prevails, not technical superiority alone. Now, let's go back to spine endoscopy. Uniportal endoscopy is hands down, and without a doubt, the least invasive technique available to this day. But it is also very expensive with a different size endoscopes and instrumentation, not to mention the training fees and the somewhat steep learning curve. The overall heavy cost in money and education time is, I think, the main reason why Uniportal failed so far to take down the old surgical techniques. On the other hand, the one-set-fits-all biportal endoscopy is much more affordable and user-friendly, making it easier to spread among conventional spine surgeons. The future is not set in stone, but it seems that in the long run, UBE is on the course of becoming the dominant endoscopic technique, enabling a majority of conventional spine surgeons to adopt endoscopy, potentially attracting more interest and investments from the industry, bringing further research and development. Maybe both techniques will continue to coexist, either synergically, where a surgeon could master both and use them tailored to each individual case, or just like Bluetooth and Wi-Fi are both used for a specific wireless communication. Maybe they will be opposed, they will remain opposed, just like the operating systems of our connected devices. Either way, our common goal as a federation is to promote spine endoscopy, which has proven time and again its effectiveness and safety, and bring down the high tower of the self-proclaimed gold standard techniques. Any surgeon can choose for himself whether uniportal or biportal suits him best, ideally mastering both. There should be no dogma nor supremacism. Both techniques are innovative, both are safe and effective, and both are helping many patients worldwide. As for which technique will survive the test of time, I will let Enya answer that. And there's no sound. It's okay. It was a matter of time. Thank you.
About Game Boy. Now in grass, I did more than 2000 UBE, and I'm now work with Ralph Wagner, who did more than 5,000 monoportal, 6,000. We have everything to do both techniques. So I've tried to learn monoportal, and he tried to learn UBE.
This is the ideal, mastering both.
But the problem is, it's totally different technique. When Ralph starts to do UBE, he's starting from zero. to masterize monoportal, it's not that you to do EB. And to do EB, for monoportal, it's new thing. You have a new Lorentz curve to do. It's a totally different technique.
Sailesh, please put up your
maybe.
talk, please. Yeah,
Dr. Nadir.
I agree with Maxime that both the techniques are totally different. And the basic principle, though fluid dependent, though scopic in nature, one applies a more vertical posturing, has a limited maneuverability to my personal liking. UB is a more inclined surgery. Both achieve the same goal. But for both, the learning curve is different. If you're doing one, adaptability to the other becomes naturally easy. And like you mentioned at the end, that both are going to be synergistic in their growth. Both are wonderful forms of surgery. Totally acceptable. It's a wonderful talk. Thank you.
Maybe, Dr. Nadir, maybe you can add one more parameter. How much A and B is going to cost to the patient at the delivery end? Uniportal and biportal, how much it is going to cost for that particular patient, considering the areas? It will be different in Korea, it will be different in India, it will be different in Argentina. So that also, because patient is going to pay for it, or the insurance company is going to pay for it. So insurance companies may have control over the pricing. So whether that is going to affect, that is also one more important thing.
Sure.
You have to think of it and include it afterwards.
That is where he mentioned the cost effectiveness of UB is going to be much higher to the doctor as well as to the patient. Because where your monoportal scope costs thousands of dollars,
no, but because of that,
scope is much cheaper.
The amount to be charged to the patient increases or not? That is important.
That is secret. That is secret.
Because after 10 years, endoscopy is going to survive or not, it is going to be dictated by the insurance companies and the amount of charge patient is going to pay.
Let's just keep it a secret for some more time.
Sir, that depends on the surgeon, which car he wants to buy.
You're right. I mean, the surgeon wants to buy a Mercedes.
That is the learning curve. Initially, you charge less, operate more. At the elder stage, you operate less, charge more.
Sailesh is going to buy the latest Merc. Come on, Sailesh, repeat.
Thank you, Dr. Paisunji and the Federation for this wonderful Congress. I think it's too late. I will just try to be as swift as possible. So this is, we are going to talk about navigation-based endoscopic spine and mainly what is our experience and no disclosures. As a routine, I'm a standard spine surgeon, but I've started doing endoscopic surgery in last 1-2 years. And this is our plethora of certain cases where we all are doing endoscopic, someone is doing destendu, someone is doing uniportal, biportal, and this is a grade 3, grade 4 high grade listhesis. And can we do endoscopic fusion in this case? Can we do reduction in this case? Yes, this is what we are sharing with our experience and what all challenges one can have in doing reduction in this grade 4 listhesis. We are doing high grades for a very long time. We have our own techniques of reduction by using short fusions, distractions at level above and coming back to the reductions because they go back and again it becomes a very, very challenge when you're doing it. Then we did MIS fusions and now we started doing high grades and different cases with this. If you see the pelvic tilt is 42, PI is 62 and sacral slope is 20. This is very, very challenging when we start doing endoscopic surgery. The triangulation, the angles, everything is very, very different. And we are lucky because we have some good experience of doing decompressions and fixations in standard grade 1-2 listhesis with endoscopic surgery. And I will not go into this detail because it's the triangulation, the angles are very, very important. And what becomes challenging is that very, very narrow zone here when you are putting the cage. There are two ways to skin a cat. One is that in standard, either you put a cage first or you put screws first. In high grades, we have started doing the opposite side screws, distract open, do a discectomy, again distract, release it, do this maneuver couple of times so that you get some amount of releases. If you try to just put your cage, you will never get a reduction. And we have developed a technique of reduction over the cage, and that's what we have used. Navigation is a great help in this because you are exactly targeting where you want to place your cage, where you want to put your screws, how you want to maneuver this reduction. And these are the challenges which we are lucky with the navigation, and navigation is helping in big way. You really can get away with these kind of cases by putting your rods, distract, reduction, and you can get this answer at the end of it. We were very happy, and this is one of the toughest cases which we have done so far. Mostly we are doing grade 1 and grade 2s. We are not venturing into very high grades, but this was a young patient and we thought of giving ourselves the best shot, and luckily we have a large experience of navigation and OARM for a long time now. And you can see the final outcome. If you see the pelvic tilt, it's really significantly improved. If you see the PI remains unchanged. The sacral slope significantly better. And you see the lumbar lordosis also. You really can get a very good sagittal profile in these patients. And this is what we really want. And I think this is going to be the future. We have recent publication in JBJS with our navigator-based cervical spine surgery. And just this week we got it. We are doing navigation-based UB for all standard cases, hybrid. This is 2-level where we did UB fusion at 1 level and decompression discectomy at 1 level. The biggest advantage of navigation, the OARM gives that real time. You really can see over the top. You can see exact how much level you have decompressed from, and no radiation. It's a radiation-free thing. Minimalistic, 13 seconds you can do a low-dose scan, and then last 5-6 years we have had no single radiation for our complete staff because we are just checking it on navigation. We are putting it becomes easy, right side, left side, up migrated, down migrated. You are just on the job. You are doing your work there and you are doing the job. It is similar like navigation everywhere. And these are our experiences with certain cases. 2 levels, we have done a couple of cases. And these are our publications in navigated surgeries in the past with OARM, with MIS. And in osteoporotic spines where you really can get a precious pedicle, you don't miss the pedicle. That's the biggest advantage. You can get a long length screw. If you see, the screw length is up to the anterior cortex. That really gives a good hold, and if you really want to reduce, you really can use this. These are the big advantages of using navigation, because 3-dimensional view, which you never get it in 2D, which is taken with this. And cervical spine, you can really get away with, we all know all this GPS and all this. These are the very standard thing, how you want to navigate. All these things are very standard. And if you want the exact target, I think this is the future. It's a costly equipment all over the world, but I think as time passes, everyone will start using this very conveniently because the costs will start coming down and different companies will start coming in. The other cervical spine revision twice operated anterior short neck and C7T1 with hand weakness. Again, if you see in this image, this is what before starting your case, you know where your lesion is, where the migration is in cervicothoracic level, and you are just going there. This surgery takes 30 to 40 minutes for an expert hand. We are not saying that it will make a bad surgeon good, but it will be a big assistance to a good surgeon. It will make a good surgeon better, that's for sure. And you really can get in, get the disc out. It's like a big brother or some godly hand is supporting you on table, and that's a big advantage of navigated endoscopic spine surgery.
a 3D image which was captured before surgery. Yes, please. And if you see, the needle markers are exactly at the disc level. 2, 3, 4, 5, 6, 7, and we are going towards 6 and 7 disc space. Go on the right side, please. This side, the needles are on this side. Yeah, go on this side. Go this side, go this side. And we are seeing the needle, which is here, exact this space.
It's an amalgamation of technology, and it's not that we have invented, but we are innovating with our own experience. And I think this is going to be the future. I will not go because every one of us is doing it in their own ways. The cage placement becomes a very, very good thing. You don't have to think twice. We are not used 2 cages, but we are planning to use 2. You can exactly identify anterior, middle, wherever you want to place the cage, and you really can get away with the screw placement. As usual, you will never miss or breach your medial or inferior wall, which is most important in fusion surgery. And there are the different cases where you can see it on table that the placement of the cage, screw, everything looks absolutely appropriate. Thank you. I will not take much time. I have a lot of cases, and thank you very much for this invite.
Any question to Dr. Sailesh?
Yeah. We can have a marking. And
Dr. Ashwin, can you load your K last talk, please? Dr. Khange?
Thank you once again. Okay.
The next talk will be by Dr. Ashwini. He is going to speak on the right-handed approach, right-sided approach to the right-sided pathology by a right-handed surgeon by UVE.
Already doing unilateral biportal endoscopy. So I think most of us are already doing it. So this talk is basically for some beginners who may or may not be there. So I first saw UB surgery half a decade ago by Professor Yoom Jin Hwa and Dr. Jin Sung Kim in 2018-19 in South Korea. And after that, COVID struck. I came back, and couple of years back, I met Dr. Malcolm, who held my hand and taught me this excellent skill. And that's why I'm standing here in front of you all. Yeah, exactly.
Most of the time it happens with Mac. I had twice only I had to shift to open, otherwise no.
No, I don't want this. Presenter mode नको. नहीं. Direct चाहिए.
Good.
ठीक है.
तिकडे टाकतो ना.
On. So my talk for today is a right-sided approach by a right-handed surgeon to a right-sided pathology by UBE surgeries. So UBE, as Dr. Pao has beautifully mentioned in his paper, is a surgery where a high definition arthroscope with a high definition camera is used along with routine spine instruments to visualize the posterior spinal anatomy and perform precise surgical maneuvers with minimum damage to the underlying tissues. So when the surgeon, who is a right-handed, stands on the left side of the patient, he gets a natural trajectory or angulation to the lamina. This is fine when the surgeon and the pathology is on the left side of the patient. But what if the pathology that patient is suffering from is on the right side of the patient? So these are my disclosures. So right-sided pathologies may be difficult while tackling from the left side of the patient. Standing on the right side is a challenge to endoscopic spine surgeons that is not natural for a right-handed surgeon to get a good natural trajectory. So what are the solutions? The surgeon may stand on the left side of the patient and make his portals on the left side of the patient. But the base of the spinolaminar junction or the base of the spinous process may migrate his arthroscope and instruments towards the facet joint and may create an issue for the beginner. The second thing that many experts do is they stand on the left side, they make portals on the left side, and they go over the top or the contralateral sublaminar way and perform the decompression on the opposite side. Some surgeons stand on the right side, as Dr. Malcolm sir advises that they are on the right side, and the arthroscope is held in the dominant hand, and the non-dominant hand has to be trained in order to perform the precise surgical maneuvers. So in this technique, the surgeon stands on the right side of the patient, and the portals and the viewing portal is created slide 2.5 centimeter caudal to the working portal. So this viewing portal is caudal now to the working portal. So normally when we are planning a left-sided approach, first thing that we do on a CM, on a prone patient is first we mark the midline. We mark the medial pedicular line, we mark the spinolaminar junction, we mark the viewing portal trajectory, working portal trajectory, and 2 portals are planned. The cranial one is the arthroscopic portal, whereas the caudal one is the working portal. Whereas in the right-sided approach, similar way, the midline is marked, medial pedicular line is marked, spinolaminar junction is marked. The working portal is planned exactly as a mirror image of what we have already planned for the left side. And we don't think much about the viewing portal, we just mark it 2.5 centimeters caudally or 3 centimeters depending upon the posterior obesity of the patient. The 2 incisions are planned and the surgery is started. So they'll be showing some cases. This is the first case. This is the case of a right-sided L4, L5 highly down-migrated lumbar disc herniation. You can see that the scope is coming from the caudal end. At 12 o'clock position is the cranial lamina or the L4 lamina. The burr is burring out the medial part of the IAP. This is the specialized diamond burr, hooded burr. Now, if we are standing on the left side, as we can see that when we are performing on the left side, the cranial laminectomy is very easy. For the right side approach, the caudal laminectomy is very easy. As you can see, just performing the laminectomy, the ligamentum flavum retracts off. It just wants to give space. And that's where the J point, where the junction of the caudal lamina and the SAP is there, is the part where our stenosis or the exiting root compression, lateral recess compression is lying out. Then with the ballpoint nerve hook, en bloc hemiflavectomy is performed. The axilla was explored with the help of a ballpoint nerve hook. And the disc herniation is delivered. I'm sorry, I'm not able to fast forward this on the presenter mode. As we can see in the C-arm image, this one is the 5 or 6 mm one ballpoint nerve hook, which is lying exactly on the posterior vertebral body, like tracing the whole down migrated disc herniation. So complete fragmentectomy was done and then radiofrequency annuloplasty was performed. This is the case of C5, C6 right-sided cervical disc herniations. After clearing the V point, we are using a number 1 Kerrison Ronger to perform a caudal laminectomy, C6 laminectomy. We can see that the scope is coming from the caudal end. The working portal is on the pathology in line with the disc space. And the visualization with the help of a 30-degree scope is as good as in left-sided approach. So there's the nerve root and the dura. This is a double-ended probe. The patient had an excellent relief even with this de-roofing kind of thing. Not big fragment was not there, but this next case is the L4, L5 right-sided ULBD. Now we could have even started with the left-sided approach in this type D Shiza's extreme stenosis case, but the patient had mainly right-sided symptoms. They were prominent. So I like to do choose the side where the symptoms are more. So we started from the right side. This is slight an issue with the right-side approach that like in this case the hooded burr is used. Because the camera is coming from the caudal end, we are unable to visualize where we are burring because of this hood. So what I found out that a non-hooded burr or high-speed neuro burr without a hood is better to perform this cranial laminectomy. This is the caudal flavum release. As you can see that the flavum just wants to come out. There was a lot of bleeding. Hemostasis was difficult because I think it was an extreme stenosis case. Contralaterally, the ligamentum flavum was released from undersurface of the contralateral lamina, and I did a piecemeal excision of the contralateral ligamentum flavum, contralateral half of the ligamentum flavum. This is from right to left actually. Okay, this is a fourth case, fusion case. Sorry, I don't have the video, but this is an extreme stenosis case. We performed the TLIF from the right side. Insertion of cage in a right side approach for a TLIF is better from right side because we are in line with the disc surface, and is better to be done in high lordotic cases, patients who have large lordosis. The last case is a L4, L5. This was a case where 15 years back laminectomy was performed and patient presented with severe right-sided leg pain. A L4, L5 recurrent disc herniation was diagnosed. So again, scope coming from the caudal end, the right hand, dominant hand performing the surgery, releasing the scar tissue, finding out the anatomical landmarks, releasing the, slightly undercutting the medial part of the IAP. So luckily for me, there was some remnant ligamentum flavum that was lying underneath this bone. The scar tissue was opened up with a double-ended probe. Using the end plate of kerosene to dissect and cut simultaneously. And the disc herniation was found just beneath the flavum. I didn't try to remove the whole flavum and do all those because there was a lot of scar tissue here. Yeah, so we can see that the herniation can be seen there. Yeah, this point. The herniation was removed and radio frequency ablation was performed. So I think the limitations of a right-sided approach are that the burring of cranial lamina is restricted. It's tricky with the right-sided approach if you are using a hooded burr. So better to use a non-hooded diamond burr or high-speed neuro drill. Also, the cranial laminectomy with the right-sided approach is difficult if you don't have a rotating kerosene or if you are not a beginner, an expert. So it's better to orient yourself with a left-sided approach before venturing to a right-sided approach. So meticulous preoperative planning is essential before you perform, and we need to understand where the arthroscope, it doesn't matter where the arthroscope comes from, either it can be medial, cranial, caudal. What matters is the working portal should be precise and perfect. Thank you. Any questions?
Any questions?
So I totally disagree with your presentation. Totally disagree to one, to the end, to everything. The first thing, when you say there is three possibilities, you can go, you can stay on left side, you could go under spinous process, you can go for opposite side. In UBE, it's easier to go under spinous process. So it's not for master, it's for all UBE surgeons. you learn to go under spinous process, and a lot of times you go to take the discardation from opposite side. On this, I was a lot of time with Dr. Son, the key of UB, to go to opposite side. The other thing is, you know, you need to know the three possibility. You need to go to stay on left side, to go on right side, to go on spinous process. You need to masterize the three technique if you are expert. And you need to select the technique for your target, for what you need to do. Like all your case you show, I'm do differently. Because I'm work, I go to opposite, I will go always to opposite side. And like the last case, revision of discectomy. If you, okay, last case, last case, if you stay on left side, you do medial approach, you will do a little bit facet joint, or you see the passing nerve root. So you don't need to do arthrectomy as you did in your case. Because if you stay on left side, if you do medial skin incision, you will dock on docking point, and after you will go to recess. So you need to masterize the three techniques.
Yeah, so Dr. Maximus, your point is excellent. Because you are an expert surgeon, you can say these things. What will be your advice to your first 10 cases? What advice will you give to yourself for your first 10 cases? And if you get a right-sided pathology like this, you can't say, no, I can't do it, I won't do it. So what will be your advice to yourself?
Ashwin, 1 minute.
You know what's interesting?
Maxim, let me just put it in a nutshell. His technique is nice as far as down migrating, as far as axillary discs go. It is an option. It's one of the options that he's proposing to do. There is what you said, what you rightly pointed out, there is a blind spot in his technique as far as undercutting of the facet is concerned, as well as for an up-migrate fragment is concerned. But what he also suggests is right, is in the sense that for a beginner who is a little scared and who wants to do something in a particular manner, it can be done. I mean, it's a can be done approach that he's talking about.
I'm saying it can't be done. I don't say it's not, but...
So I accept it at that level. I accept it at that level.
If you want to make right to be, right technique, right principles, all 5 cases, you do differently.
True. It is like what Dr. Siok Bong Jong spoke today, and even Dr. Yumjin was mentioned today, that you eventually have to learn the right technique, and you eventually have to go for doing things the right way. Because what happens is when you're going to do a para T-lift, or when you're going to do a external T-lift, or when you're going to do a para UB on the right side, then this approach is not going to work. So as a halfway measure, yes. For a person who's beginning his career, yes. I don't say no. It's an excellent thing, that is an excellent concept that he's brought. But when it comes to doing other things, more aggressive things that are going to be needed in UB, you need to develop a particular level of ambidexterity and little adaptability. So I accept both ways.
You know, UB is not...
I'm political.
You know, UB, you are political, you know,
Dr. Maxim, for the last case, what would you have been approached?
For
The revision case, right-sided herniation. How could you approach it from the other side?
I will explain you. I'm going from opposite side.
Yeah.
And you make your skin incision.
Where?
From right side.
On the right, that's what?
Yes, but.
So that's what, what the incisions have to be on the right side.
No, I will explain you. You make the skin, when you stay on left side, you operate right side, you make skin incision more medial.
Yeah.
You do usual, you find yourself after, you will see lamina passage joint. You do a little bit, and you will find the passing nerve root.
Okay.
If you go from opposite side, you make huge arthrectomy to go to recess.
Even in a revision laminectomy of 15-year-old laminectomy,
because
what will be your anatomical landmark when you try to dissect?
You see lamina.
Which lamina?
Lamina, upper lamina.
On the right side?
Yes. You dug. After you see lamina, facet joint. Or you drill under the facet joint.
Okay.
So you do the minimum arthrectomy.
Okay.
If you go to right side, you need to do huge arthrectomy. The principle should be, if you work like this, or you need to follow with the principle to do all cases. You need to masterize all possibilities,
So you always start on the left side.
No.
I think we will.
You always stand on the left side.
Ashwin,
I
we will.
adapt myself to case.
All brains are exhausted now. We need some. We need to increase our spirits. Yeah. So we need some dose of alcohol to understand these special concepts.
Thank you all.